Okay, we are officially recording and let's get into slideshow view. Perfect. So everyone should be able to see diabetes, all related concepts. So we're going to be focusing on type 1, type 2 diabetes. There is a such thing as gestational diabetes. You guys will, of course, go over that when you do the maternity review, when the instructor gets to that portion. So we're just focusing on type 1 and type 2. Okay, so let's go ahead and get started. And also, you guys who've been with me before, you guys know I like students to be very interactive. So for the new people, you can always type into the chat. If you have any questions, if you want me to repeat something, please type into the chat, or you can always unmute yourselves and join in the conversation, add some input, or again ask questions. Same thing, we go through the NCLEX questions, type your answers into the chat always, and then of course you can always unmute and add input as we go through the questions. I like the students to be very, very interactive when I do my webinar. So diabetes and all related concepts. So this is our objectives for this evening. Okay, just basically overview of how to join your every webinar. So for me, I am mostly on Sunday nights and Wednesday nights. I'm usually the 9 to 11 slot, Sunday and Wednesday, unless something comes up in my schedule and I can't do a Sunday or a Wednesday. That's usually the nights that you'll catch me. Okay. Plus, I do adult health concepts and mental health concepts. I believe it should say my name. I'm not sure when you guys sign up for the webinar if it says my name or not, but usually it is adult health and mental health Sundays, Wednesdays from 9 to 11. I always do 9 to 11 slots just because of the schedule that I have. So that's when you pretty much catch me Sunday and Wednesday. So these are our objectives for this evening. Okay, just very simple objectives. Pretty much hope you guys have a better understanding of diabetes, the signs and symptoms, comparing type 1 to type 2, making sure you understand how to care for these clients, complications, which of course would influence the way that you assess these clients. Hello, Virginia Beach, which will definitely give you insight as to how to care for these clients, because you're definitely going to care for clients differently based on the type that they have. And of course, the education that you give them is also going to be based on the type of diabetes that the clients have. So first up, what exactly is diabetes? So as we've already determined, we're going to be talking about type 1, type 2. So this is an endocrine disorder. So this is an endocrine dysfunction disorder, and it is a chronic disorder, which means there is no cure. Okay, that's the first thing we need to understand about diabetes. There is no cure. What we do is we say that it is well controlled. So if a client, originally starts out with the labs or the signs and symptoms, once the labs get into within normal limits, the blood glucose mainly, and some other labs that we like to look at, once everything gets into normal limits, we don't say that the client is cured. We pretty much say that the client has well controlled diabetes. So if ever you need to do, can you share screen? I am screen sharing. Can everyone see the screen? If you can see my screen, you guys type into the chat, yes or no. Yes, 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 yes. Okay, so someone asked me to share the screen. You know what I'll do for you? Let me stop sharing and then I'll reshare. Maybe that'll help you. The one who said that asked me to share the screen. Okay, so now I am sharing again. It's very tiny, so that may be your settings on your end. That might be your settings. I'm sorry, I'm not techie at all, so I couldn't even tell you how to fix that. But it may be your setting. Now okay. That's probably why I stopped it and reshared it. Perfect. So again, it is a chronic disorder, endocrine system dysfunction. There is no cure. We want to make sure that clients understand that when you do education, especially when you talk about NCLEX questions and you do education, you're educating the client to make sure they have an understanding of their disorder. Sometimes clients have an unrealistic understanding of what they have, and it is your job as the nurse to provide education to correct that. Okay. So the two types of diabetes, which we will go into, you have type 1, type 2. Type 1 is insulin dependency, which means that client will have to give themselves insulin injections, or depending on the doctor, may order some implantable insulin type device that releases insulin on its own. based on the readings that it picks up regarding blood glucose. Okay. Type 2 diabetes, you do produce insulin, but for some reason, usually weight, the body doesn't respond to the insulin that is produced. So typically, type 2 diabetics do not need insulin. However, there are some percentages of type 2 diabetes that will have to have insulin injections because their type 2 diabetes is not controlled conventional ways. Um, so the differences between type 1, type 2. So this is the pathophysiology. Okay, very simple. They both have pretty much the same start in terms of genetic dispositions and environmental. So that means this could either run in families or it could be something environmental that triggered, the diabetes. Typically with type 1, we see it more in childhood development, adolescence. Type 2, you typically see more developing in adults. Um, since we did kind of mention gestational diabetes, when it comes to gestational diabetes, gestational means pregnancy related. So if you have a client that's pregnant that is not diabetic going into the pregnancy, you know that we screen them between 24 and 28 weeks. For those women who do develop gestational diabetes, a small percentage of those clients will develop type 2 diabetes at later life. Normally, when women give birth, when they have gestational diabetes, it's almost like they're out of the woods. Giving birth is kind of like a cure for their gestational diabetes, but very small percentage of those women will go on to develop type 2. So we will continue to screen their blood glucose just for that reason. Now, when it comes to the pancreas with type 1, again, something happens to the pancreas. Okay, there's damage to the pancreas, the islet cells, which produces the insulin. Something happens. Again, it could be environmental, it could be due to an infection, an attack, but for some reason, the pancreas becomes damaged and it is not able to produce insulin like it normally should. Okay, so for that reason, you would have to provide yourself with the insulin that your pancreas should have normally produced. Excuse me. For type 2 diabetes, you do produce insulin. So it's not an issue with the pancreas. It's not an issue with the cells that produce the insulin, the islet cells. Nothing is wrong with them. For some reason, your body just rejects or doesn't react to the insulin that you are producing. For a lot of people, this is due to diet and weight. So usually when it comes to managing type 2 diabetes, it is somewhat of an easier way to manage it. It don't always involve insulin, but more or less just diet, exercise, weight loss management. And for a lot of clients, their diabetes become well controlled with type 2. Okay. So, how else does type 1 and type 2 diabetes differ? Again, type 1, your body doesn't make enough insulin or doesn't make insulin at all. Type 2, your body just doesn't respond to insulin. Sometimes with type 1 diabetes, it can be an immune system response. That means the body, for some reason, just attacks itself. Think of autoimmune disorders. So, type 1 diabetes can have an autoimmune component to it. So, things like arthritis, lupus, okay, those are autoimmune disorders, myasthenia gravis. For some reason, something triggers the body, and then the body starts attacking its own organs, its own cells. So, sometimes there is an immunological component to type 1 diabetes. And again, we have no understanding of why in autoimmune disorders, the body just all of a sudden just wants to attack itself. Okay. Again, type 2 diabetes is more of lifestyle issues. Again, diet, being sedentary, meaning you're not really active. Smoking does play a big component. Sometimes with type 2 diabetes, there are coexisting conditions like hypertension, which kind of makes type 2 diabetes a little harder to manage. Again, type 1 starts typically in childhood. Types 2, we see more in adulthood. Now, we're not saying you as an adult cannot develop type 1 diabetes or we won't ever see type 2 diabetes in children. It's just majority of the time we see type 1 diabetes, it does develop starting in childhood, and type 2 diabetics tend to develop in adults. Um, Type 1 diabetes, believe it or not, the symptoms come very, very quickly. When your body is lacking insulin or not able to use insulin, you see these symptoms very quickly. So it's more of an abrupt onset. With type 2 diabetes, okay, it is more of a gradual onset. Now, you do see some of the same signs and symptoms. However, like I said, the onset with type 1 is a little more gradual, a little more quicker. And then type 2, you tend to see those signs and symptoms much more gradually, meaning you don't even know So no, you don't cure. And I said that in the beginning. Instead, we say well controlled. Okay, that is a big misconception with type 2 diabetes, that diabetes is curable. Once you develop diabetes, you're never really cured. It's more or less, we say it's well controlled. Your glucose is well controlled. Your body is utilizing the insulin that you produce, because let's say if you were to gain weight back, you can slip right back into type 2 diabetes with the high blood glucose and so forth, so forth. So instead of saying cured type 2, say well controlled or well managed. Okay. Treatment with insulin, again, type 1. Type 2 is more managed with what we call oral glycemic agents. Okay. And again, very small percentage of type 2 individuals will require insulin, but that just depends on how well their type 2 diabetes is controlled. Usually with type 2 diabetes, we see non-compliance as a really, really big issue, meaning clients are not sticking to their regimens in terms of taking their oral glycemic agents, like they're supposed to, or they're not taking the diet, seriously, which we say, low carbs pretty much, and more vegetables, more meat, get a little more active, drink more water, cut out the sugary snacks, stuff like that. Okay, so usually with the type 2 diabetics, it's again more of a non-compliance issue, then it's just not working what they have prescribed for them. So again, this is just a little more extra info about type 1 versus type 2. It is very important that you understand the different types of diabetes, because again, this determines the type of treatment that the client will require. This determines how we will manage it in terms of education, in terms of the complications that you watch for. Okay, because even though you may see some of the same complications, there are complications that are more common to type 1 and certain complications that are more common to type 2. So when you sit for the NCLEX, okay, they have to specify what type of diabetes the question is referring to. Because again, this is going to change the whole concept of what am I treating, or what am I looking at, or what am I educating about. And again, it is all based on the type of diabetes that the client has. Okay. So hopefully with those couple of slides, you have a clear understanding between type 1, type 2. The basics is type 1 is insulin dependent, type 2 is non-insulin dependent. That's the easy way to break it down. But then you also have more specifics that you can also, keep in mind when it comes to understanding your different types. So these are the risk factors for diabetes. And this is also type 1, type 2. Both of these are mixed in here. Family history. Okay. So there is a genetic component to diabetes, which means if you have a close relative that has diabetes, for example, a parent, a grandparent, a sibling, your chances of developing diabetes are increased. Okay. Race and ethnicity plays a role. African Americans, okay, or Black people, we have the highest risk of diabetes development. Native Americans, Hispanics, they kind of follow behind. But when we look at the statistics in terms of, the demographics, it is Black America, or Black people in general. I'm not necessarily saying Black Americans, but just Black people in general tend to have the highest. Because remember, these are statistics from this country. So I'm pretty sure, if we look at other regions, you might not see, the numbers in terms of, Black people from, other regions. And a lot of that has to do with diet. Okay, let's talk about it. Okay, the Westerners, our diet is not the greatest. Okay, when you look at diets of other cultures, a lot of things that we eat, they do not consume. So that is why this is referring to Americans in terms of the risk factors, because definitely depending on the region you are in, okay, the numbers are definitely different. Okay, with age, there is an increase, and that's typically type 2. Okay. Again, obesity plays a huge role, and we're seeing a lot more childhood obesity now. Back in the day when I was young, and back in the day in the 80s, so I'm pretty much just gave away my age, but back in the day in the 80s, listen, we was active. Okay. When we got home from school, we couldn't wait to go outside. Do your homework, clean up, whatever your parents had you to do. We couldn't we rushed to do it because we wanted to go outside and play with our friends. We wanted to ride our bikes. We was playing kickball. We was active. We was outside. If you look at the generation of young kids today, a lot of things have replaced the activeness that us kids used to do. This technology, video games, handheld games, kids are more inside, kids are more sedentary. They're not as active as they used to be. So we are seeing childhood obesity on the rise. And with that becomes the more diagnoses of diabetes. So there is a link. And the food, listen, the foods these kids eat, and I'll be very, very honest, and it's not at a total fault to the parents. Sometimes the junk stuff is the cheap stuff. I mean, let's talk about it. You guys see what's going on with this economy in America. Prices of food is going up. It's very expensive to eat healthy. It was expensive then to eat healthy. It is more expensive to eat healthy. So a lot of times, people are just eating what they can afford. And a lot of times the cheap stuff is not the healthy stuff. So definitely diet has played a huge role in the numbers of, diagnoses, especially in children going up. So yes, what somebody in the chat said, oh, let me take this off. Somebody in the chat said the foods, and that's definitely a huge issue with the foods. Again, physical inactivity, lack of exercise. So when people say exercise, people think you have to do a lot to exercise. You really don't. If you can stand, 3 days a week, 30 minutes, walking, that constitute as exercise. You can find something that you enjoy to do. I always, always, always talk about swimming. Swimming is fun, and swimming is a great way to work out. A lot of times, certain physical activity might be hard on the body, hard on the joints. It's not enjoyable. But if you want to do something fun, swimming is that, or just getting in the water aerobics, swimming. That is a good way to burn calories, and it is fun. Okay. I have kids. I always talk about swimming. Kids love the water. Zumba. Yes. Listen, let me tell you, I used to do Zumba, and I fell and I ain't never go back because I was embarrassed. So now, I brought my son one of those Oculus, the Facebook Meta, whatever they call it. And now you can do that stuff from the comfort of your own home. I ain't got to go to nobody class. I am home in the comfort of my own privacy. So I could look a mess, I could fall. Nobody dares to see it. But you just have to find ways to exercise and have fun with it. I know some clients, they have those not the big oh gosh, like the machines that you walk on or you can run on. For some reason the name just slipped my mind. But they have little small ones and they watch TV while they're walking on their treadmills. Thank you, Juliet. Thank you. For some reason, it just totally slipped my brain. They watch their shows while they're walking on the treadmill, and the next thing you know, you've done 30 minutes. If you're watching a 30-minute show, you've done about 30 minutes. Or if you're watching an hour show, you've done about 45 minutes. So a lot of my clients, they incorporate, as long as you're active, we'll take it. I am not picky. I'm not choosy. I just tell the clients just get active some type of way. Okay. So signs and symptoms. Now, these are the general signs and symptoms. They are definitely much more than this, but these are the typical signs and symptoms that you think about when you think diabetes. Okay. Now, we tend to focus a lot on hyperglycemia because, of course, that is high blood glucose. That is the hallmark sign for diabetes with the meeting ID. John, what's wrong? When you say someone help you with the meeting ID, what do you mean? I want to make sure that you're okay before I keep going. You can type it to the chat or you can unmute yourself. Or whenever just type it to the chat, whatever issue that you're having. So I think it's
Okay,
some
so
administrative. Yes.
I'm trying to invite a friend, and she's asking for the for the ID.
Really, she should be able to join.
Yeah, that's what I said, because when I tried myself, it didn't ask me for the ID, but she's new, yes, so and I want her to be part of it.
Is she able? There you go. There you go. Thank you. Thank you, thank you, thank you. So there it is. I think I was about to copy and paste it myself. Let me see if this is the same one that I have. Yes, it is.
Wesley, can you hear her? Can you hear what they're saying?
Okay, so I'm going to mute you so that you have the meeting ID there. I'm just going to mute you so you can talk to your friend, the person, and have them to join in. Okay, so again, going back to signs and symptoms, these are the classic signs and symptoms that people think about when they talk about diabetes. And again, the emphasis is always on hyperglycemia because, of course, that is what high glucose is, hyperglycemia. That's when you start seeing the signs of diabetes. However, okay, you also have to understand hypoglycemia because sometimes we can treat the client so well that they go to the opposite end of the spectrum and they become hypoglycemic. And being hypoglycemic is just as dangerous as being hyperglycemic. So, with hypoglycemia, one of the things that I put it together to help me remember a lot of times when people are hypoglycemic, you might think that they are under the influence or they're drunk. That's one of the first things that I learned and remembered when I was in school. You know, the slurred speech, um, the confusion. They might have rapid heartbeat. It's like when you watch them, when they talk, when they move, it's almost like, is this person drunk? Like that's kind of sort of the first thing that comes to your mind. They may have tremors. Okay, jitteriness, tremors, profuse sweating. When we say profuse sweating, we're talking about diaphoresis. Okay, that's just a little more than just sweating. So, profuse sweating. Of course, they're hungry. Okay, some may have headaches, some may complain of dizziness, some may have difficulty concentrating. Okay, so those are your classic signs of hypoglycemia. Then on the flip side, hyperglycemia, we start with the three polys. Anytime you think of diabetes, hyperglycemic signs and symptoms, you always start with the polys: polydipsia, polyuria, polyphagia. So, polydipsia is increased thirst. Okay, polyuria is increased urination, and polyphagia is extreme hunger. Okay, so the polys is where you typically start. Then you have the other signs and symptoms. You do have the blurred vision, headache, nausea. Sometimes, depending on how high the person's glucose is, they may experience some respiratory issues. Okay, they're called Kussmaul's reparations, and I think there's listed in the PowerPoint further down. But the respirations we tend to see with the hyperglycemia, Kussmaul, um, rapid, very rapid deep breathing. Okay, and then also the confusion, and then you have other signs and symptoms that some people might not think about. Now, we talked about, going to the bathroom a lot, polyuria. We talked about fatigued, um, blurry vision, some other, always hungry, always thirsty, but some other signs and symptoms people don't think about. And this comes from having the chronic high glucose and not having it properly managed. So these are some symptoms you may see again after the diabetes has been existing for a period of time. Numbness and tingling in the extremities, more specifically the feet. Okay. And when you say numbness and tingling, that means that the person's ability to feel is decreased. Okay. You can call it diabetic neuropathy. Okay. So if you ever see the term diabetic neuropathy, there's issues with sensation. And that's a problem because when we talk about things like, gauging water temperature, especially if you're taking a bath or a shower, if you experience diabetic neuropathy, you have a chance you can burn yourself because you are not able to distinguish how hot the water is. So a lot of times we tell individuals, you're welcome. So a lot of times we tell individuals, check the temperature of water. Okay, before you get into it, check the temperature because with diabetic neuropathy, your ability to feel is diminished. There is no password, if I'm not mistaken. You should be able to join right in. On my end, I don't see the meeting the generated meeting IDs, but I've never students just normally join in. Do you guys have to have a password when you guys join in? Oh, there you go. Thank you, Jen. Jen is always here. Thank you so much. See, I don't see that on my end. Thank you. See, that's what it's about, helping each other. Thank you so much. Okay, another sign of diabetes, okay, wounds that do not heal or poor wound healing. That is another hidden culprit of diabetes. So, what does that mean when it comes to taking care of clients as a nurse? And this is always NCLEX material. Okay. If I have a client that is diabetic and I know that they, poor wound healing is a manifestation, when I have a client that has to have surgery, okay, I'm concerned because when you have surgery and you have incisions, that's technically a wound. Okay. We talk about things like not walking around barefoot. Okay, that's a big part, and we will go into more details with that because of the diabetic neuropathy. One of the things we advise clients, do not walk around barefoot. When you have a decreased sensation, that means your ability to feel pain is also decreased. So it's not just about being able to tell the temperature of things, your ability to feel pain is decreased. So let's say you step on something and it becomes a sore. Okay. When it becomes a sore, what happens is poor wound healing, it becomes severely infected. The next thing you know, you have severe infection, becomes sepsis, worst case scenario, we would have to amputate that extremity. Okay. For women, increase in vaginal infections. That is another hidden culprit. Things like yeast infections, vaginitis for females. Okay. That is a hidden culprit of diabetes. Okay. Sudden weight loss, especially if you're not trying. Okay. Sometimes we're envious of people because they lose weight so quickly. It's not always healthy weight loss. So if you're just all of a sudden losing weight quickly and you're not trying, definite red flag when it comes to diabetes. Okay. Problems having intimacy with a partner. And when you say problems, it could be a male or female problem. Okay. Sometimes men may have issues with erectile dysfunction. Sometimes women have issues, just being in the mood and, it may be painful. Okay. Those are all issues with intimacy. So sometimes we see the problems in relationship related to the complications of diabetes or the side effects, which is problems with intimacy as well. Okay, so it is 9:30, almost 9:40. Let's take our first breather, okay, because we're all about diabetes, so we're going to take a break. It is 9:40, so let's say 9:50. Okay, let's take a quick little breather. 9:50, we'll come right back and we'll keep going. And again, eventually we will get to our diabetes questions. Okay, so everybody, 9:50, I'm going to put it into the chat what time we will be coming back. Okay, everyone, let's get back into it. Okay, there's my video. Okay, so let's get back into it. So we just finished our symptoms. So let's get into diagnosing, okay? And when it comes to education questions on NCLEX, a lot of times clients may ask, why do I need this test? Why do I need this medication? Or what is this for? So it's important that you understand how we diagnose diabetes, whether it is type 1 or type 2. So the first type of test that we do is called the glycosylated hemoglobin, or shorthand HbA1c. Okay. Now, this, in my opinion, is the granddaddy of all diabetes testing. So this test goes back about 2 to 3 months. Most literature will say 3 months, and it goes over your glycemic index control. So in other words, this test is going to tell providers how well you have been controlling your glucose going back 3 months. And that is typically the lifespan of a red blood cell. Okay. Now, this test you cannot lie your way into. Okay. If we ask you, how you been eating the past couple of months, the past 3 months, and you say, you know what, I haven't eaten pretty much any carbs, I eat nothing but fruits and vegetables and meat. If I do eat carbs, it's very minimum. I've been drinking, diet sugar-free soda. You could tell us all of that. And it sounds great. Okay. But then we do the HbA1c and the results tell a different story. So we like for your glycemic control to be 6.5% or less. Okay, so again, that tells us how well you have been controlling your blood glucose levels going back 3 months. Okay, anything over 6.5% is problematic. Now, you can be slightly over 6.5%, you could be 7%. While that is not under 6.5, that is not the worst of the worst. You can be something that we call pre-diabetic. That is a possibility. Okay, you're not going to be officially diagnosed as diabetic, but if you don't control it now, you can be on your way to becoming diabetic. Okay, so again, the HbA1c, glycosylated hemoglobin, that goes back the lifespan of a red blood cell about 3 months, and it's going to tell us your glycemic control. So, how well have you been controlling your diabetes going back 3 months? Okay, then we could do what is called a fasting blood glucose. So what we will tell you to do, you will fast overnight about 8 hours. So we'll tell you, depending on when your appointment is, don't eat anything past 12 midnight. That's normally the standard. Okay. Don't eat anything. If you do have to have something, drink water, nothing with calories. You are fasting. Okay. Then you come in the morning. Of course, we're not going to make you fast all day like that. So you come in first thing in the morning. And then what we're going to do is we're going to draw your blood glucose. Okay. And this is what a fasting glucose is. So when you don't eat for that extended period of time, we expect your blood glucose to be lowered. Okay. If you fast for over 8 hours and your glucose is high, in this case, over 126, that is a huge red flag because you fasted for over 8 hours and your glucose is this high. So this is supposedly low for you. So imagine what your glucose would have looked like if you actually ate a meal. Okay. So if your glucose after fasting for about 8 hours is over 126, that is a red flag. So what we will do is we will do another fasting glucose because of course nobody wants to jump to conclusions. You could have slipped up, you know, but we're going to say, listen, we're going to do this test one more time. Same thing. You're going to fast overnight starting about 12 a.m. midnight. And then we're going to do a fasting blood glucose. If you have two separate occasions fasting glucose of over 126, red flag, you are confirmed to be diabetic. And then, of course, we start from there with managing. The next type of test that can be done, and you guys, I'm randomly checking the chat. So if you do type a question, I will eventually catch it. Okay. So the next type of test that we will do is something called the oral glucose test or the oral glucose tolerance. Okay. So this is really, really simple. You are going to come in, okay, fasting, same thing. You are going to fast, and then we're going to give you a very high carb drink. Usually it could be about 75 grams. So if you can imagine, that is super sweet. Okay. About the same amount of sugar that's in a typical can of soda. And this is a straight carb, sugary, syrupy drink. You need to drink the whole thing. Okay. It may cause a little nausea, common, especially if you're not used to eating a lot of sugar like that. But we need you to drink the whole entire thing. And then what we're going to do is we are going to test your glucose after that. Now, of course, we're going to test your glucose before because we have to have a control. So we're going to test your glucose after fasting. Okay. And then we are going to, is that the drink? Yes, it's the same type of drink, Christine. That is exactly the same thing. So Christine asks, is that the same type of drink they give when you are pregnant? Yes, if you are not diabetic going into your pregnancy and you need to be screened for gestational diabetes, it is the same concept. They're going to give you a high carb drink, high sugary, syrupy drink. They're going to take your glucose before, and then they take your glucose about an hour afterwards. Okay. If you are over 200 with this particular test, because we expect your glucose to be higher, that is a lot of carbs you're drinking at one time. So if your glucose is over 200, okay, after an hour, that is a red flag. They may do the same thing that we do with the, pregnant women, where we test your glucose 1 hour, 2 hour. Some doctors like to be 100% sure. They don't just go off the first result, because it can come down considerably the next hour or so. So some doctors will like to play it safe. And rather than take the first glucose reading, they might take a 2 hour reading. They may take a 3 hour reading. That is the same type of test we do for pregnant women. You can do the 1 hour challenge. You can do the 3 hour challenge. Okay. In most cases, to be sure, they may do just the 1 hour challenge and tell you to come back and then do a more extensive test. Okay. But if you have to do the 3 hour, listen, make no plans because you're going to be there for a while. Okay. And then the last type of test that we can do is called a random plasma glucose test. So this is just random
Excuse
throughout
me.
the.
Someone
Yes.
was asking how many hours for the fasting blood glucose?
How many hours? Oh, okay. Thank you, thank you, thank you, thank you. I saw Christine, but I didn't see yours. Um, so for the fasting, about 8 hours is adequate. So typically they'll tell you, nothing past 12 a.m. And normally your test might be 8, 9 a.m. in the morning, and you cannot have anything. Okay, so at about 8 hours is adequate. You want to make sure that you fasted enough to make sure that you get a good adequate reading. So anything under 8 hours is probably not that reliable. So that's why they'll usually tell you nothing past midnight. Okay, you're welcome, no problem. So with the random glucose, that is just taking your blood glucose at any time of the day. It doesn't matter when you've eaten, what you eaten. You can just regularly eat and we'll just randomly just check your glucose. Or we'll teach you how to just randomly check your glucose. Okay. Again, anything over 200 along with the other symptoms. So this is a little different from the oral glucose tolerance, where 200 and over is a red flag. With the random plasma glucose, okay, in addition to having a glucose over 200, we're going to assess you for the other signs of hyperglycemia. For example, the polyuria, the polyphagia, the polydipsia, the neuropathy. We may check to see how your vision is doing, because blurred vision is a manifestation of chronic diabetes. It's a couple of different things that we're going to look into. So in addition to having an over 200, you have to have the other manifestations also to help confirm the diagnosis. So this is the 4 ways that we can check to see if a client is diabetic. Remember, the typical most reliable would be the HbA1c, the glycosylated hemoglobin, because again, it goes back about 3 months, the lifespan of a typical red blood cell, to see how well you have been controlling your glucose for the past 3 months. A client might fake the other ones, right? I might can do something to try to lower my glucose, try to fake the test. You definitely cannot do that with the HbA1c. Going back 3 months, there is no way that you can fake your way through that. So we have clients and we ask them, so how you been the past 3 months? And they give you, oh, I've been doing great. I've been following everything. That HbA1c will give it away every single time. Okay. So management, let's get into the management ways that we treat diabetes. So remember what I said, depending on the type that you have, treatment and management is a little different. So of course, with type 1 diabetes, we start with insulin therapy. And I do have a slide that talks about different types of insulin. That is something that you will need to know. And when I say what you need to know, we'll go into that when we get to that slide. So type 1 diabetic is insulin dependent. Okay, there are different types of insulin. They have different action times, which we'll talk about. So the doctor may prescribe you, sometimes it's not always gotten right on the first try. Sometimes doctors may prescribe you, combinations, single types insulins. Usually it depends on, how high your glucose is. Okay, because all insulin is not created equal. So usually it is, administered based on your particular need. It is administered via an injection, and it is a subcutaneous injection. So you want to make sure you understand that, because when you are teaching an individual who is, newly diagnosed type 1 diabetic, they have to learn how to give themselves injections of insulin. It is sub-Q. Okay. And we will talk about nursing management, what exactly you have to educate regarding insulin administration. Okay. Insulin administration needs are adjusted. So don't think, you're going to be that same unit for the entire duration of time. It is going to fluctuate. Okay. When we see that your glucose is really, really, really controlled, meaning it's not even as high as it normally is, the doctor may adjust your dose. Okay. Now remember, you still will need insulin regardless with type 1, but if we can get your dose lowered, that indicates you have good control. Okay. We're also going to teach you how to monitor your blood glucose. Now, this is NCLEX, prime NCLEX. Okay. If you are experiencing signs and symptoms of hyperglycemia, either or, the question is, what do we do? What do the nurse do? What does the client do? Remember, and this is typically a, priority type question. What should I do first? Okay. Remember, if by chance you just don't understand what to do first, you have to think about how to prioritize. Okay. When it comes to the nursing process, and this will be a time to implement that, you have to do an assessment first, then you plan, then you intervene, and then you evaluate, and so forth, so forth. So if I have a client that is exhibiting signs of either hypo or hyperglycemia, before I do anything, I need to assess the glucose, because I don't know what's going on with the client. Yes, they're showing the typical signs, if they're hypoglycemic, jittery, trouble with concentrating, confusions, extreme sweating, you know, they could be having those signs and symptoms. But what if they truly are alcohol intoxicated? They're not hypoglycemic. So before I say, oh, I need to give them this, I need to do this, you need to always assess first. Same thing on the flip side. If they're showing the signs of hyperglycemia, before I do an action, I have to know what I'm treating. I have to know what I'm doing. I need to know what to report to the doctor. So I have to do an assessment first. And again, this is prime testing. You always assess before you do an answer. So regardless of what symptoms the client is exhibiting, and let's be honest, let's keep it real. We know what this stuff looks like. We know what, a seizure looks like. We know what, hyperglycemia based on the client's, signs and symptoms. We know hypoglycemia. But for the NCLEX, you cannot do an intervention, which would be treatment, until you do an assessment. You need to know what you are treating. Okay, prime testing material. Okay, let me just check the chat. Also, we focus on a healthy diet, of course. Listen, you got to lower those carbs, period. Okay, less carbs, more protein, more vegetables. That's the typical diet. Okay, now, do you have to cut out carbs 100%? Absolutely not. I mean, unless you just have a very limited diet, you're not going to cut out carbs 100%. But you can choose foods that are healthier or lower in carbs. Even certain fruit are very sugary. So you're just choosing food options that are lower carb options. Okay. A lot of food that you may think is healthy, and let's say it has a lot of protein, but it also has a lot of carbs. So you might want to, choose healthier versions, lower sugar versions. But that's typically where we go with the diet. Okay. Whole grains, when you say low glycemic, low carb, meals, and we teach you how to carb count, that's important. We teach you how to add up carbs based on servings. That's another thing we have to teach clients. What is a serving? Listen, we so used to just eating We don't count servings. You cook something and it's 6 servings, but you just ate 2 without even realizing you ate 2 servings. So we teach you how to diet. We teach you how to choose meals wisely. We teach you how to proportion. Okay. And then, of course, regular exercise. So, whatever way you can get active, get active. Okay, if you can get a step counter, that's a real good way to get active. You get a little step counter, you set some goals for yourself walking around work. One thing I do on my campus, I walk around a lot. And sometimes I don't have to walk, but I just do. So I try to get as much steps as I can get in. Sometimes I just take walks just to take walk. If I'm in between classes, I got a little extra time. I just try to walk because you want to stay active. You want to stay moving. Being sedentary, meaning not being active, that is the worst thing for a diabetic that you can do. Okay. Education on diabetes. So we may, set you up with a diabetes educator. Okay. Now, the nurse is very well capable of educating on diabetes, but sometimes, especially with a brand new client that's having a little bit of trouble, you may want to pull in an expert, and that is okay. Like, for example, when it comes to breastfeeding, I am a nurse. I can teach a woman how to breastfeed, I can monitor, I can make sure she's doing it correctly. I can tell you the foods to eat. I can do all of that. But if you're still having trouble, maybe I need to consult with a lactation consultant. So it's the same thing with this situation. There are diabetic educators, people that are specifically trained to teach and talk about diabetes. Okay. And then last thing, regular checkups. Listen, you got to go to the doctor and get checked. Okay. You cannot run from diabetes. You can't hide. You can't avoid it. It is what it is. You need to get regularly checked by a professional, not, you went to Walgreens and, you brought an over the counter glucose monitor, which you can do. Okay. And you just regularly check, oh, my glucose is great. I'm checking it. It's low. That's not enough. You got to go to the actual doctor because you don't just get your glucose checked. There are complications of diabetes. So you have to get body system checks, cardiovascular system. Okay. For one, a big risk factor of uncontrolled diabetes is cardiovascular disease. So you have to do more than just let me check my glucose throughout the day to see how well or how low my glucose is. You need to go to a regularly, scheduled appointment once a year, twice a year, depending on the doctor, and you need to get actually checked. Compliance is big when it comes to managing diabetes appropriately. Okay. So now let's talk about our insulin types. Very, very important. Definitely NCLEX testing material. Okay. So there are typically 4 categories of insulin types. Okay. Rapid acting, short acting, also known as regular acting. So if you see the term regular acting, that's another name for short acting and vice versa. Intermediate acting, which is typically insulin called NPH. And then you have long acting. Okay. Now, how they get their names, it's based on onset. Onset means how fast does this insulin start working? So when it comes to the NCLEX, what type of questions could you see? A typical question is if I ate something at 7 a.m. in the morning and I take a rapid acting insulin at 7:30 in the morning, when do I expect the insulin to start working? That is a typical question. Or if I took a short acting regular insulin at 9 a.m., when do I expect the peak? The peak, so onset is when the medication can start working. So that's onset. Okay. So for rapid acting, that is the quickest of acting. You take rapid acting, you could expect it to start working on lowering your glucose within 5 to 10 minutes of administration. That is very quick. Okay. Oh, I have a chat. Let me see. Sliding scale. We'll talk about sliding scale. Okay, that's a great question. We'll talk about that. So again, if I take rapid acting, I expect it to start working within 5 to 15 minutes of me injecting myself. Now, the peak indicates the time frame where the medication is the highest in your body before it starts being metabolized or broken down. Okay, medications have a peak.
Can
Okay,
you repeat that?
repeat what?
The peak.
Okay, no problem. So the peak is the medication is in its highest amount. So before it starts being broken down or before it starts being metabolized. So the peak is whatever point in the body the medication fully reaches the bloodstream and it is at its peak, it is at its highest amount. Because once the body starts metabolizing it, your body will start secreting it, or your body will start getting rid of it, which is what the kidneys do. Okay, so after I take rapid acting insulin, I would expect it to start peaking, and this is a range between 30 minutes and up to 2 hours after I have taken rapid acting. Everybody is different. Everybody's metabolism is different. The way that everybody's bodies metabolizes or break down medications is different. So it is a range. So again, I'll say that again. So I'll give you an example. If I take rapid acting insulin at 8 in the morning, that's a regular, just a random time. And when I'm talking about the peak, so before my body starts to metabolize or break down my insulin, what time frame do I expect the insulin to be fully in my body? The amount that I took fully in my bloodstream for rapid acting, that is from 30 minutes to 120 minutes. So if I took it at 8 a.m., I would expect it to peak in my blood between 8:30 a.m. or 2 hours later, 10 a.m. Okay, those are the types of questions. Peak time expected hyper. Could you explain that? BS. So you asked me peak time expected hyper or hypo. Now, if I think I know what you're asking me, it's about controlling glucose to lower it, because that's what you take insulin for, to lower your glucose levels after you've eaten. Pretty much, you can take it at other times, but that's pretty much what the purpose is. So you're trying to lower hyperglycemia. Now, can you lower the insulin too good? I mean, the glucose, you absolutely can. Sometimes people take too much insulin. They don't follow directions, they don't measure it. Okay, because that's a part of education, teaching people how to measure the insulin based on the order. Because if you take too much, you can drop your glucose significantly, and now you're hypoglycemic, which again is just as dangerous as being hyperglycemic. Okay. And then you have duration. Duration is another thing that we look at in terms of insulin. Okay. Duration indicates how long can the insulin work. So onset, how fast does the medication start working? Peak, how long does the medication stay in your bloodstream before it starts getting metabolized or broken down? So when it's at its strongest, that's the peak. Okay. Or when it's the most that is going to be in your bloodstream at one point, that is the peak. Okay. Duration, how long will this insulin work on maintaining my blood glucose? That's duration. So even though rapid acting insulin works fairly quickly, its duration of time that it works in your body is 3 to 5 hours. Okay, so when it comes to NCLEX questions about glucose, they can ask you different things. If I take rapid acting at 7, when do I expect it to start working? If I take rapid acting at 7 a.m., when do I expect it to peak in my bloodstream? That means between 30 minutes and 2 hours. Okay, if I take rapid acting insulin at 7 a.m., how long would I expect the duration to last? Between 3 to 5 hours after you first took it. So that means after 5 hours, that rapid acting insulin is no longer working to lower your glucose. Okay. And that is what we teach clients. They have to understand how their insulin works. Okay. Short acting is regular insulin. And there's two types of regular insulin. So if you guys see here for the names of the insulins, okay, you have U100, which means unit. U stands for unit. And then you have U500. So depending on what type of control the healthcare provider is going for, they can order you 1 unit or 5 units of insulin. So if I took the U100, that is just 1 unit of insulin versus the 500 unit. So for every 1 unit of insulin, if I took the U100, I'll be times in that by 5, put it like that. So if I took 1 unit of the 500, instead of it just being 1 unit, it'll be 5 units. So it'll be 1 times 5. So if I took 2 units of the 100, Okay, that'll be 10 units in the 500. So it just kind of, multiplies by 5 as you go up units. You have to be very careful with the units because again, you can take too much. The worst thing we want to happen is we control your glucose so well. That's a real thing. We control your glucose so good that you're no longer hyperglycemic. Now you're on the end of it. You're hypoglycemic, which means we got to stop the insulin and give you something to bring your glucose back up. Okay. So as you can see, the onset's 30 minutes, the peak, depending on the type, 2 to 4 hours or 4 to 8 hours duration, depending on how much, 5 to 8 hours, 14 to 15 hours. Okay. And then you have your intermediate acting. Okay, those are your humulins, your novolins. 2 to 4 hours it takes to work. So this takes a little longer. So as you've noticed, as the insulin types changes, the time they take to work changes also. So that is why we have to explain to clients when should you take a certain type of insulin or when should you expect this insulin to start working because of the onset. Okay. And then the long acting, which is exactly what it sounds like. It takes the longest to start working. Okay. 1 to 3 hours for certain types, Lantus, which is a typical long acting 2 to 4 hours. Now, this type of insulin does not have a peak in most cases. That means this insulin, if a provider starts you on long acting insulin, you will take it at regular intervals according to what your doctor prescribes. So you're keeping a steady level of insulin in your body if you take long acting. So this is like a maintenance insulin. Okay. This is not, I just ate and I need to take some insulin. That's not what this is. This is long term maintenance. So this is to keep a steady level. So this could work even overnight while you're sleeping. Okay. That's this type of insulin. I took this insulin and even overnight it's helping to control my glucose. So again, this is more of a maintenance type of insulin. Okay. And as you can see, some of these long acting can work 24 hours. Oop, oop. I told y'all my computer is so sensitive. So this can work 24 hours until the next dose. This is one you would take like that, you know, and again, steady amount of levels of insulin throughout the body, even works overnight while you're sleeping. So depending on the severity of your type 1 diabetes, and everybody has different types of type 1, some people they need a little more insulin to control the glucose. Some people need a combination of glucose. Some people need the maintenance, regardless of whether you're eating or not. Your glucose is so out of control. We need to give you a medication that will consistently keep your glucose lowered. That would be long term. Okay. So for NCLEX testing, you need to know when would the medication start working and how long does it stay in your body until it starts to break down. Okay. So managing type 2 diabetes. So this is the type that is non-insulin dependent unless you are that few percentage that still needs insulin. Okay. So the first thing we do is weight management. That is the first thing that we look at with type 2 diabetics. Can you lose weight? Because a lot of times the insulin is resistant because of the weight that people carry. Okay. Your body is producing insulin. So it's not the pancreas. The problem is the insulin is there. Your body is just rejecting it or your body is not recognizing it. And for most people, this is a weight thing. So the first thing we're going to try to do, we need to lose some weight and we're going to help you. I know you guys know these medications on the market now, Ozempic. What else? Gosh, Ozempic. What's the other one? Gosh, I can't remember all these names. There's so many of them. Ozempic is another one. Manjaro. There it is. I couldn't think of it for nothing. Ozempic. Huh? Go ahead. Someone was about to say something. Hold on. Somebody is writing. Who is writing? Emily. Let me erase this. Let's see if I can erase this. Oh, hold on. Give me a second, you guys. Let me try to get these lines. There we go. Oh, I was able to get one off. Come on. Oh, this one is not coming off. Oh, there's one. There we go. Looks like I gotta click it at a certain. There we go. Perfect. Oh, Miss Emily, girl, I think you might be taking notes or doing something, but you are writing on the screen. I can't get this one to come off. There we go. So let me go back. So with type 2 diabetes, again, this is non-insulin dependent. We start with weight management. Let's lose some weight. Let's try to lose. The more weight you lose, even if it's a pound, that will help control your glycemic control better. Okay. Metformins. Yes, 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 yes. So oral medications. Now, the most common drug is metformin. Now, here's the thing. What a lot of people discovered with the metformins, the Mounjaros, the Ozempics, they found that it also suppressed the appetite. Now, originally, okay, these medications were for helping you to control type 2 diabetes. People with type 1 diabetes do not take Ozempic, well, they shouldn't. Okay, they shouldn't take Ozempic. They shouldn't take Mounjaro. These are type 2 diabetic medications because again, type 1 is insulin dependent. This is to help you control your glucose, eventually get your body to use the insulin that you are producing. So originally, that's what it was for. We put clients on Ozempic, we put clients on Mounjaro. Trulicity is another one. Metformin is another one. And it was, you come back and let's check your HbA1c, or let's do a any time of the day glucose check. And we were seeing that the glucose was being controlled. But a surprising side effect was appetite suppression. And they started to notice, wait a minute, people that not only is their diabetes getting controlled, their glucose, but they're losing weight. And they're losing weight because they're not hungry. So of course, they started marketing it as a weight loss drug. Now, most insurances, they will not cover it if you are not type 2 diabetic. For most insurances that I'm pretty sure of, you have to be type glyphosate, that is another one. Yes, those are all type 2 or glycemic agents. You have to be a type 2 diabetic, or you would have to pay out of pocket. Not saying you can't get it, but you would have to pay out of pocket. And apparently, diabetic medication is very expensive. So that is what they market it as now, an appetite suppressant drug. Okay, but again, it was really for helping to control glycemic index. Blood sugar monitoring. Listen, you need to check your blood glucose throughout the day. You don't need to wait till you come to the doctor. Go, purchase one of those over-the-counter glucose monitors. Your insurance may cover a glucose monitor device. And Wegovy, okay, y'all naming all of them. Yes, Wegovy is another one. Semaglutide, I don't know if you ever saw that name before. Semaglutide, that's another one. All of those are glycemic agents. So again, get you a glucose self-monitoring and check your glucose throughout the day. Check it in the morning, check it after you eat, check it at night. Also, if you're feeling jittery, if you are feeling confused, if you having slurred speech, check your glucose. Now, you might know, listen, I'm jittery, I'm slurring, I'm confused, I'm having a difficult time concentrating. I probably need to eat something. My glucose is probably low. You know that. You know your bodies, you know what you're feeling. Zepbound, yes. Why y'all just naming all of them? Yes. Y'all naming all of them. You know you're hypoglycemic, and you would probably say, you know what, I need to eat a simple snack, because that's what we tell you to do. But in the eyes of the NCLEX, you need to check your glucose first. You always assess before you perform an action. That is classic NCLEX testing strategy. You cannot do it, even if you have an idea of what it is, even if you feel like 100%. Dexcom is another one. There's some that is implanted that helps to do the same thing. So even if I'm hypoglycemic, let me just eat, drink some orange juice, let me eat a cookie. You're supposed to check your glucose. Okay, regular checkups. You have to attend regular checkups, making sure you are being managed appropriately and making sure there is no side effects or complications. And then, of course, we support lifestyle management, losing weight, no drinking, no smoking. Smoking can increase the effectiveness of diabetes. Okay, we talk about diet management. Okay, losing weight, improving sleep. Believe it or not, sleep ineffective patterns can affect diabetes management. Okay. And also a hidden culprit, stress. Listen, stress will complicate your diabetes. Okay. Cortisol, the stress hormone. Cortisol is not a friendly hormone. It's not a good hormone. The stress hormone. You got high cortisol in your blood. What are you so stressed out about? Now, nursing school, we get it. Okay. Everybody get it. You are stressed out. That's nursing school. But when it comes to type 2 diabetes, you have to create a healthy host. Your body is a host. You have to create a healthy host in order to manage your diabetes. So, one of the things we do focus on is stress management, whether it's learning how to deep breathe, whether it's learning how to do anything that's going to help relieve your stress, you have to incorporate that in your lifestyle because stress is a hidden culprit of making diabetes more complicated, okay, or causing a lot more complications. What time is it? Let's take, oh, right on time. Now we're about 10:25. Let's take our last breather. Okay, get another little break in because we're actually almost done. And once we come back, we'll finish complications management. And I think there's one more slide, the advanced stages of diabetes, and then we'll go into our NCLEX questions. So it is about 10:25-ish. Let's say 10:35. Okay, so that's about 9 minutes. Good, a short little break. Okay, so 10:35, we'll be back. Continue. We will finish out diabetes and then we'll get into our NCLEX questions. Oh, looks like, let me see. Give me 1 second. Okay, there we go. Perfect. So, complications of diabetes. So, the reason why we advise clients to keep up with regularly scheduled appointments, even if your diabetes is well controlled, is because of the complications that can arise from having diabetes. Okay. One of the most important things we look at is cardiovascular health. A lot of people with uncontrolled diabetes, they can develop heart disease, which means higher risk for myocardial infarctions or heart attacks, higher risk for strokes, higher risk for peripheral vascular disease. That is a lot of where the neuropathy comes from. And remember, neuropathy is a decreased feelings, decreased sensation. These are the individuals who we tell you, you need to check the temperature of water before you get into them, especially if you take a bath. A lot of times you have clients that like getting pedicures. Let's talk about it. Okay, when you put your feet in the pedicure water, it could be extremely hot. If you have decreased sensation, you're not realizing how hot water is. And then again, you're definitely at risk for, hypoxemia. Your vital organs are not getting oxygenated properly because you have a problem with blood flow. Okay, we know that kidney disease is also a complication of diabetes. Diabetes can damage kidneys, and worst case scenario, your kidneys become so damaged you would need dialysis. So this is called nerve damage is neuropathy, and kidney disease is nephropathy. So those are two different words. They do look similar, but nephro means kidney. So one of the things that I teach students, try to learn how to break words down. If you just really having a hard time understanding what a word means, sometimes if you break it down, it kind of helps you to figure out what the word means. And nephro means kidney. So with kidney disease, we know that the kidneys will have an inability to filter. That is a problem because the kidneys is what keeps our blood clean. It filters, it helps to get rid of toxic waste and things like that. So if your kidneys are not functioning appropriately, that is where we start to see, okay, the buildup of kidney failure. And again, those will be the clients who need to start dialysis. Okay, or worst case scenario, transplant. Diabetic retinopathy. So these are the eyes. Diabetics are encouraged to get regularly scheduled eye checkups. Okay, we know that one of the side effects is blurred vision. So that comes from eye damage. So we definitely need to get your eyes checked regularly. The vessels in the eyes become damaged. The retina can become damaged. Retina is like one of the main components of the eye that helps you see. So we talk about retina damage, that could be irreversible. Okay, leading vision loss, blindness, and that's something that you would not be able to get back. Foot problems. So this is a huge one. Okay, this is why we tell clients do not walk around barefoot. Okay, make sure you have on some socks or something when you walk around, due to the fact that you have a decreased sensation, which goes back to the nerve damage, the neuropathy. Worst case scenario, someone with diabetes steps on, let's say, a nail, okay, or steps on something that causes a sore. And we already said poor wound healing is an effect of diabetes. So now you have a sore on your bottom of your foot. You don't know it's there because you didn't even realize you stepped on something. It becomes severely infected due to poor wound healing. The next thing gangrene has set in, sepsis has set in, and there's a possibility that extremity needs to be amputated. And you see that a lot with diabetics, amputations. So that is why we go over nursing management. We encourage clients to keep up with regularly scheduled checkups, especially with the podiatrist. And a podiatrist is a foot doctor. So of course, being a foot doctor, you would think majority of the clients are diabetic. And lastly, other complications that people don't think about when it comes to diabetes, gum disease. You wonder why your gums are bleeding, or you wonder why you always have gum infections, sore gums. That is a component of diabetes complications. Cognitive decline. When we talk about the development of cardiovascular disease, peripheral vascular disease, and you talk about, the decrease in blood flow. And also a lot of times people with diabetes have co-conditions or comorbidities, meaning they have typically something else, and it's normally diabetes and hypertension. A lot of times you see one, you see the other. So diabetes coupled with hypertension, you're definitely talking about some issues with peripheral vascular health. So you're talking about blood flow to the brain being affected. So we start to see the cognitive decline, the confusion and things like that. And remember, and I always say this when I talk about the brain, that is one of the only organs that do not regenerate. When you have permanent damage to the brain, that is typically irreversible. You cannot get that back. So we talk about cognitive decline. There is a possibility that it can become permanent depending on how much of the brain is damaged. Some clients may experience hearing loss with uncontrolled or complication of diabetes. Please, what is okay? Peripheral vascular, no problem. So your peripheral vascular is your arteries and your veins. Okay, arteries carries oxygenated blood. So when blood leaves your heart, it leaves your heart through the arteries, and the arteries is what carries oxygenated blood to your organs, your tissues, your cells. Everything needs to be perfused appropriately in order to, stay healthy. Or blood return going back to your heart. That is your veins. Okay, so your veins carries deoxygenated blood back to your heart so it can become oxygenated again and go back out to your body. So it's like a cycle. When you have peripheral vascular disease, whether it is arterial, which is your arteries, which carries oxygenated blood, or your veins, which is also known as venous insufficiency. I actually did a webinar on this. So if you go back, I don't know if that was March, maybe go back. If you go back, you should see it if the recording is still there. So if you have trouble with blood returning to the heart, that means blood is pooling, meaning it is sitting, it is not circulating. That is also a problem. What happens is you're at a higher risk for blood clots. DVT, for example. So when you have peripheral vascular disease, whether it is arterial or venous, you're going to have an issue either way. With arterial blood flow, you have trouble getting blood to vital organs, vital tissues to be perfused. That also is a culprit for something we call paresthesia. If you ever heard of the term paresthesia, the numbness, the tingling, decreased sensation, that is a huge side effect of poor arterial circulation. Another issue, the extremity is cool, the pulses are weak, a movement is decreased. That is, something that we see when you have poor arterial circulation. And then with poor venous circulation, again, blood is just sitting in your extremities. It is not returning to your heart. Pooling blood, increased risk for DVT. Worst case, they turn into PEs. The DVT dislodges, and the next thing you know, you have a clot traveling to your lungs or your heart or your brain. Okay, so when we talk about clients with those type of conditions, it's very, very important we keep up with checkups, because if you do develop peripheral vascular disease, depending on the type, either your organs or your tissues are at risk, or you're at risk for clots. So it totally just depends on what type of disease process you have. Does your tongue tingle? Also, just curious. Um, that's a great question. Usually you see the tingling in the extremities. Okay. So the numbness and the tingling, we typically refer to the hands and the feet. Now, could the tongue become affected when we talk about risk for frequent infections? We talked about yeast buildup. You can develop oral thrush with diabetes a lot. Just like you can develop, you can have chronic yeast infections. You can have the oral thrush, which is the same fungus, the yeast, the same thing. Okay, so it would be more of that. So if you're talking about tingling from that, you could definitely see it that way. Okay, you're welcome. No problem, John. You're welcome. Um, Hearing loss and dementia. So again, all of this is cognitive, decreased blood flow. If dementia does run in the family, diabetes can complicate it and make it worse. Okay, so we talk about older people with dementia and diabetes. It is very important that it is controlled effectively because it speeds up the decline in cognitive functioning, which is what dementia is. And I believe I just talked about that this past Sunday. Okay. So, more complications of diabetes. Now, this is when we're talking about extremely high levels of glucose. Okay. So, we're not talking about, your 180, your 200. We're talking about high, 500, 600, and things like that. So, there are two complications: DKA, which is called diabetic ketoacidosis, and then you have HHS, hyperosmolar. Oh, looking at my phone. Hyperosmolar. So that is something where you have very uncontrolled diabetes, but your glucose has skyrocketed. Okay, very, very high. So again, this is beyond 200. We're talking about hundreds, very, very high. Usually you see DKA in type 1 and you see HHS in type 2. Okay. DKA is more commonly seen. HHS is rare, but it can be seen in type 2 diabetics. With HHS, you are more likely to see other issues when it comes to body functioning, body systems. With DKA, is normally limited to just the endocrine, uncontrolled glucose. DKA can last several hours. If we catch it soon, we start treating you, giving you insulin, something to bring down your glucose levels quickly. It can last a couple of hours to a couple of days. HHS tends to last a little longer. When it comes to NCLEX questions, more likely they test a lot on DKA because of the manifestations. Now, when the body is in ketosis, okay, and keep in mind, this is the basis of the keto diet. So I know you guys have heard of the keto diet. It's the same concept. When your body goes into a state of ketosis, and this is DKA, diabetic ketoacidosis, you lose weight. That is why, going back to signs and symptoms, losing weight effortlessly. You are not actively trying to lose weight. The weight is just melting off. And a lot of times people, oh, my metabolism is high. It's not necessarily your metabolism. Your glucose is very, very high. Your body is in a state of ketosis. So you are dropping weight without even trying. Another aspect of DKA, the acetone breath. Okay. When you are in ketosis, your body builds up ketones. Okay. And that is how, when people do the keto diet, that's how they check their bodies to see if their body is in ketosis, because you do not start burning fat until you are in a state of ketosis. So you check the urine. The urine is releasing ketones. That is how you know you're in ketoacidosis. Okay. Also, the breath, it becomes very fruity. Acetone. If you ever smelled acetone, that's kind of sort of what the breath smells like. Okay. So fruity acetone breath, ketones in the urine, rapid or quick weight loss. Okay, that is typically DKA. Again, HHS is more rare, seen with type 2 diabetes. Sometimes you don't even know you have HHS. The symptoms in the beginning are very, very mild. When you start seeing the high levels of hyperglycemia and the damages, it's because it has, been there for a little while and the person just was not checking, or they were ignoring their symptoms. So with physiologicalness, we say for DKA, ketosis or ketoacidosis. That's the main thing you need to know, and the manifestations that comes with ketoacidosis. Let me see in the chat. Yes, up to even higher. Higher than that. It could go higher than that. Okay. Somebody put in the chat 600, higher than that. I had a client a while back. This was a while back, and this is pediatrics. And so the parents brought her in. She was completely unresponsive when they brought her in. So the history was she was playing and she started feeling ill. Now, one of the things that a lot of parents do when a kid is ill and they're not eating well, they give them fluids, which is not incorrect. That's what we want you to do. We want you to give a sick person fluids because we don't want them to become dehydrated if they're not having input. However, you need to give them a certain type of fluids. Not all fluids are created equal. And unfortunately for these parents, they were giving her apple juice, and not the healthy kind of apple juice, the low sugar. No, they was giving her apple juice with the high sugar content. So you got a sick child, and you are doing the right thing according to you, because I'm giving fluids, and no one taught you, if you have a sick child, all fluids are not created equal. You want to give them something with calories. You want to give them something, or just a person sick in general, something with calories, something with electrolytes, because when you become dehydrated, you have electrolyte imbalances. So for kids, Pedialyte is the best. Any type of electrolyte replenishing drink is appropriate. But these parents is giving her apple juice. So by the time they brought her in the next day, she was unresponsive. Apparently, they tried to wake her up the next day. She was very unresponsible. Or if she did wake up, she, went back out quickly. So of course, they brought her into the ER. Her glucose was over 100. And that is because they was feeding her. So apparently she was diabetic. They did not know. She was showing complications of uncontrolled diabetes. Because honestly, how many parents say, I think my kid has diabetes, let me go get them checked. So it was going unnoticed until it had existed for so long. She was having complications. Long story short, they ended up amputating her right foot. um yeah, that's how severe her condition was. So not only was she lethargic, unresponsive, she was over 600 blood glucose, and the hallmark management of DKA. Insulin, listen, you got to get that blood sugar down. You got to get it down. That glucose, you got to get it down. With HHS, it is more fluids. With HHS, you have a higher osmolarity. So that is more particles in your blood. When you become dehydrated and you lose a lot of fluids, if we were to check the blood osmolarity, it'll be much higher, meaning there's more solutes in your blood. Your blood has lost a lot of fluids. Your blood is highly, highly concentrated. So the dehydration fluid replacement, we see that more with HHS. With DKA, there isn't an issue with osmolarity, but you have ketosis. So the goal for both, you have high glucose for both. Let's make sure. But how the glucose got to that point, the physiological, that's different. Okay. So even though the goals for both is to bring the glucose down quickly, how you do it is definitely different. Because DKA is seen more with type 1, usually it's about insulin management. Okay. Now, of course, if the client is dehydrated, you can throw in some fluids. More than likely they are. With HHS, throwing fluids is automatic because they're dehydrated, severely dehydrated. So even if you was to check the pH, okay, they are severely, severely dehydrated. Let me see in the chat. Yes, 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 yes. Um, and of course, again, HHS is more seen in type 2. So unless you have trouble, you may have to throw insulin in there. But remember, type 2 is not insulin dependent. Some clients do need insulin because they have poor control of their diabetes. Okay. Let me see. So as you can see here, when we talk about pathogenesis, so this also helps you to understand the difference between DKA and HHS. Okay. This slide here. With DKA, the hyperglycemia is less, it doesn't exist for that long of a time. We can bring down the glucose very quickly managing DKA. With HHS, it does take a little longer time to bring the glucose down. It is more prolonged. Okay. I think that's pretty much it for DKA. For testing, just keep in mind the signs and symptoms of DKA: elevated glucose, ketones in the urine, fruity acetone breath. Okay. HHS, the key thing you would see, the osmolarity of the blood is high, meaning lost a lot of fluids, dehydrated. So you might see some electrolyte imbalances also. And the goal for both is to bring the glucose down quickly. It's just the matter of how it's done is different, but that is all. Both have the same goals. Even though HHS is more rarely seen, it can still happen with type 2 diabetics. So last but not least, nursing management. Okay, so teaching clients how to manage their glucose or check their glucose. Now, one of the things we talk about is sick day rules. This is a big one. Okay, this is NCLEX. Sometimes you get sick, okay? And when you are sick, you don't have the greatest of appetites. And there's a sick rule management for a person with type 1 diabetes because that's the insulin dependent. If you are not eating naturally your glucose is lower. Even if you're diabetic, if you do not eat, your glucose is low. So the question is, if I am a type 1 diabetic and I'm not eating, do I still take my insulin? Because if I'm not eating and my glucose is low, taking insulin will make my glucose even lower. As the nurse, we have to understand scope of practice. We do not have the authority to tell a client to alter their insulin dosages. That is only something the healthcare provider can do. What we can advise, if you are sick, you're not eating well, check your glucose more often. Plain and simple. Check your glucose more often. You might not need to adjust your insulin dosages because when you do eat, whenever you do have the appetite to eat, you are maintaining your glucose. So you would need to take your insulin as prescribed. The doctor is the only person that can alter or change your insulin dosages. It may be needed depending on how severely sick you are. Okay. If you exercise a lot, your metabolism is naturally higher. You need to check your glucose more often. You start feeling jittery, you start feeling, dizziness, shakiness, you might start sweating. You are hypoglycemic. You work out a lot. Okay. So those are the exceptions when it comes to glucose monitoring. And always remember, always assess before you make a decision about what to do. Okay. For medication management, we talked about insulin key points. Again, duration, peak, onset. Those are things you need to know about your 4 types of insulin. Another thing you would need to know how to draw up insulin. And I know you guys have to remember this from pharmacology, clear to cloudy. Okay. NPH insulin, regular insulin, clear to cloudy, meaning you draw up one first over the other, clear to cloudy. So we're drawing cloudy, and then we're drawing up clear. Okay. Sometimes you have to teach clients how to properly draw up insulin in addition to teaching them how to administer insulin. And trust me, that is not easy because having somebody knowing you got to give myself injections, it takes a little while to get them comfortable to that point. Foot care, you need to see a podiatrist regularly. Okay. We know that diabetics have poor wound healing, so we don't want you to step on something and it becomes a sore that doesn't heal. It becomes infected, it becomes gangrene, and the next thing you know, you have to have amputation. Oh, something in the chat. Do you need to correct client? You absolutely do. When you see questions like client statement indicates teaching is ineffective, that is when you finish teaching and a client makes a statement and the statement is not correct. That means I need to reinforce teaching. I need to go over the teaching. So when you see those types of questions, what statement indicates teaching is ineffective? That means the client did not understand what it is you taught. You would have to reinforce or follow up and correct the education. You would definitely have to do that. Um, let me see. Which insulin do you draw first? My pharmacology class. Why y'all mean your insulin suck? That is hilarious. So let me go back and make sure I got all the questions. Fluid replacements, DKA. Yes, that is correct for shy, if I'm not mistaken. Do you need the correct client education, Juliet? Again, yes, if the clients have misconception. One of the biggest misconceptions about diabetes, again, that it is curable. That is not the case, and I think I've said it enough. We say you are well controlled when it comes to diabetic management. Now, when it comes to drawing up insulin, okay, and I'm checking the time to make sure that we are on the right schedule. When it comes to drawing up insulin, okay, if you are to give clear and cloudy insulin, you can't give it in the same syringe, okay, because that is another aspect of insulin you would have to teach your clients. They may have to use separate syringes to draw up their insulin. But when it comes to clear and cloudy, that can't go into the same syringe. You just need to know which one to draw first because you don't want to cross contaminate. Okay, so the whole process of injecting air, you start that, so you, based on how much the doctor orders, and you have your special pens, your special needles and syringes for insulin because it goes by units. Okay, so you have your medications, you roll it in your hands. You're going to draw up air based on your doctor's order. Okay, and then the first thing you're going to add air to the cloudy insulin first. Okay, whichever is the cloudy, and that's typically, which one is cloudy? Is NPH cloudy or not? In the chat. So you're going to put air into the cloudy one first. Okay. And then you are going to withdraw. And based on the order for your clear insulin, okay, you are going to draw up air and you're going to inject the air into the clear insulin valve. That is the one you draw up first. So you add air to the cloudy first. Make sure you do not touch the needle to the insulin. Okay. Okay. When you are drawing up the cloudy first. Okay. Because you don't want to contaminate the cloudy into the clear. That is why we draw the clear first, but we inject air into the cloudy first. Okay. So once you draw air into the cloudy, you withdraw, you put the air into the clear valve, then you would turn over and you would draw the amount of insulin from the clear valve. Okay. Once you've drawn up your clear insulin, then you go back to the cloudy valve, which is the NPH, and then you draw up the amount from the cloudy valve, the NPH. So you can mix clear insulin and cloudy insulin in the same syringe. You just draw, technically you draw the clear first, but you inject air into the cloudy insulin. Long as you don't let the needle touch the insulin, you are fine. You do not want to contaminate the cloudy into the clear. Crossing clear into the cloudy, that's different. Okay, but the other way around, so when you're injecting air into the cloudy valve first, the NPH, try not to let the needle touch the insulin. Okay, you should have a little space between the top of the, the valve and the insulin itself. So you need to be very careful and pay attention that you are going into that little space when you are injecting your air. Okay. You inclined to go barefoot around. Yes, if your client says they can walk around barefoot, you definitely need to correct that. You should not walk around barefoot. Not that you
Okay.
can't, because I can't force you, but you shouldn't.
In your education, in your client education, where you have dietary management, it says do walk around barefoot. That's what I was asking you, if that needed to be
I see what you're
corrected.
saying. Oh, I wasn't understanding. Okay, so that is a mistake on my part.
Yes.
I missed that. Thank you for catching it. I didn't understand what you were saying. Yes, you do. It's supposed to say do not walk around barefoot. I didn't even catch that. Do not walk around barefoot. So in the recording, I am stating do not. I'm going to probably fix that. Do not. N-O-T in bold letters. Not. Okay. Thank you so much, Miss Juliet. Thank you. Okay. And then collaboration with other healthcare professionals. So we've already talked about the complications. Collaboration, it depends. If I have a client that has poorly controlled diabetes, if they need help with dietary management, I might incorporate a dietitian. Okay. If they're having other complications, we want to incorporate an ophthalmologist, someone who looks into the eyes, nephrologists, the doctors that, kidney management. You may have to incorporate different healthcare members depending on the severity of the diabetes. If it is not well controlled, we may need some outside input. Or if it's not well controlled, listen, you need to do these appointments or we need to refer you to these specialists because your regular healthcare provider, while they are trained, they are not experts. So you would need to be referred to those particular healthcare providers to make sure that you are, you're not controlling it well, but you're not experiencing those extreme side effects or complications. Okay. And that is the end for diabetes. Again, for that slide that Miss Juliet thankfully pointed out, do not walk around barefoot. And also let the podiatrist clip your toenails. That's another big one. Listen, diabetics are poor wound healers. The last thing you want is a cut or something and it turns infected. So when you go to the podiatrist and they're checking the bottom of your foot, tell them, hey, can you clip my toenails? They're more, better trained to clip because we don't want you to nick yourself and that little nick turns into something huge. Okay. So let's go into our questions quickly. Let me make sure I exit out all of that. That was a real good discussion. You guys always come with the questions and the discussion. I love it. Okay, so I am sharing my screen again. So here are our questions. Okay, so what I want you guys to do, you can type your answers into the chat, or some people like to unmute. And either way, make sure you guys participating so I can see what it is that you know. Okay, so I'm going to get into slideshow view. Perfect. So all diabetes NCLEX questions. Number 1, a client with newly diagnosed type 2 diabetes is admitted to the metabolic unit. The primary goal for this admission is education. Which goal should the nurse incorporate into their teaching plan? A, maintenance of blood glucose levels between 180 and 200. B, insulin types and administration sites. C, an eye examination every 2 years until 50. D, weight reduction through diet and exercise. So what is my main primary focus? Because this is education. I see D's, D's.
D.
So, I see in the chat, nurses cannot cut their nails. It is not recommended. For NCLEX testing, the podiatrist should do that. It should be the podiatrist when they're doing your bottom of the feet check. They should go ahead and clip your nails at that time.
And cut straight across.
And cut straight across. There it is, straight across. And the correct answer is, of course, D. Right on it as usual. Whoa. I be trying to stump y'all sometimes. So we know that type 2 is more or less weight related. We know that the body does produce insulin, so we know it's not insulin dependent. 180 to 200, that is just way too high. You're diabetic. Okay, that is not good control. We also need to teach you sites. So remember, with type 1 diabetics, and we'll get into that because there is a question about that. We talk about insulin management. Very few type 2 diabetics do need insulin. However, we don't assume that they need it. We know that type 2, you do produce insulin, your body just rejects it. So we focus on getting your body healthier so that you can start utilizing the insulin that you are producing. Type 2, question 2. A client with diabetes and peripheral neuropathy is being discharged from the hospital. What instructions should the nurse provide to decrease the risk for skin breakdown? Select all that apply. So remember, with neuropathy, you lose sensation. When you lose sensation, you lose feeling. You lose feeling, you lose the ability to feel pain. So we talk about liquids and bath water being too hot. That can definitely cause skin breakdown. So the question is, what education would I provide this client to reduce the risk of that happening? So this is select all that apply. I see BCE, I see BC. Okay, so we look like we're on the same page with B and C. A couple of people are saying E, a couple of people are not saying E.
Except between the toes. You're not supposed to put the lotion between the toes.
So it is acceptable to use hot water bottle to keep feet warm. Always wear socks and preferably shoes to protect the feet. Check the feet daily to look for any injuries. Nail clippers can be used with toenails to prevent injury. Okay. Use lotion on feet to keep the skin from becoming dry and cracked, because dry and cracked skin can become infected skin. The answer is B, C, and E. Good job. Okay. B, C, and E. Now, the reason some people didn't pick E. You can use lotion on the feet. You can keep feet moisturized. Okay. It is okay to keep skin moisturized, because skin that is not moisturized, again, it becomes dry, it becomes cracked, it can become, a wound. And we
But it
know it
should
has
not be used between the toes, right, Professor?
not between the toes. No, ma'am.
Right.
Okay, but you can keep the feet moisturized. You can. Okay. Nail clippers, the reason why D is not incorrect is because it's like telling a client that you can clip your own toenails. We advise clients, do not clip your own toenails. Again, if you clip or nip yourself, you might not even feel it, which can turn into a sore, that can turn into an infection, and so forth, so forth. So you do not clip your toenails. You always ask the podiatrist, or sometimes they'll do it on their own, realizing the toenails have gotten long. Okay. And no, it's not acceptable to use a water bottle. We already talked about it. You have a decreased sensation. So using something hot, you can burn yourself and not even realize it. And now you have skin irritation or breakdown. Number 3, the nurse is caring for a client with type 1 diabetes mellitus at 0300 hours, which is 3 in the morning. The nurse finds the client disoriented to time and place, diaphoretic, and reports palpitations. What is the nurse's priority intervention? Ooh. A, check blood glucose level. B, give 10 to 15 grams of carbs orally. C, call the healthcare provider for additional insulin order. D, administer 1 milligram of glucagon subcutaneously. And I'm seeing a lot of A, a lot of A. I think I drilled that enough. A, you always assess. Listen, you might think you know what's going on. It makes sense for me to think. I see somebody put D. We'll talk about that. It makes sense that I think I have an idea of what's going on. But again, I cannot know exactly what to do until I assess, which will be checking the glucose. And again, that will determine what do you do moving forward. Okay. Now I'm going to go back because somebody put D. Now, not saying that that's a wrong answer, but at this moment when you're saying priority, you wouldn't know if that's the priority action because you haven't checked the glucose. Like I said, you might realize what's going on without having to check, but for NCLEX, you got to do stuff by the book. You got to do stuff in the right order of steps. So when we talk about the nursing process, we always assess first before we figure out an intervention. All of the other options, B, C, and D, are interventions if you caught that. A is the only option that, A is the only option that tells you to check, which would be assess. B, C, and D are all interventions. So if I pick B, C, or D, I'm basically saying I'm doing an intervention before I assess, and that is incorrect. The assessment will guide you on what additional things you would need to do. Okay. And also the reason why D is not correct, this is insulin. Okay. It appears that the client is hypoglycemic. Let's just say, I know what's going on. The client is hypoglycemic. Giving them glucagon is going to make it worse because it's going to further drop their glucose. Question number 4, a client with diabetes is being tested for glycosylated hemoglobin. How would the nurse explain the reason for this diagnostic test? A, determines the fasting blood glucose level. B, it determines the average blood glucose level in the previous 2-3 months. C, it determines the ratio of glucose to hemoglobin. D, it's used to identify a reduction in hemoglobin because of high glucose levels. And you guys are firing off in the chat. B, B.
Yes.
Of course, the answer is B. And that's why we make sure clients understand with this test, you cannot lie your way out of this. You can't tell me you've been doing so good, and we go back 3 months and we realize your glucose control has not been great. That indicates you're not either taking your medications or you're still eating foods that are not healthy for your diabetes. Okay, good job. Question number 5, which client will the community nurse visit first? So prioritization client care. A, the newly diagnosed with type 2 diabetes mellitus. B, the client with type 1 diabetes mellitus requiring wound care for a leg ulcer. C, the client with type 1 diabetes mellitus with acute visual changes. D, the client with a random blood glucose levels of 110. So all your clients are diabetic, but who would I go to first? I am saying C's. Ooh, now what did that happen? I'm seeing a lot of C's, and there's your answer. You guys are correct. The answer is acute over chronic. Okay, yes, ma'am. Where you came from? Yes, ma'am. That is absolutely correct. Acute over chronic. So, highest priority, acute vision. First of all, that is new. Okay. Anytime you have a new development, that needs to be seen first because we know that complications of diabetes is diabetic retinopathy, which is the eyesight. So if they're experiencing new vision issues, acute, that needs to be addressed first. I would probably go to the client with the leg ulcer next. If this was telling me to put in order, I would probably go to the client with the leg ulcer next because they need addressing. We know that the poor wound healing, we know the complications. So that would probably be who I would see next. Type 2 newly diabetes mellitus, that's education probably, and that could wait. So A, I would probably see third, and D, I don't have to see it all except to truly follow up. So D would be the very last person. 110 is considered normal because we like between 70 to 120. is pretty much decent control. Anything over 120 is considered pre-diabetic, and then the higher you go, of course, the more confirmation for diabetes. But 110, I don't need to rush and go see you. Okay. They're actually raising a lot of the parameters. You remember, blood pressure used to be 120 over 80 was considered good. Now they've gone up to 130. So anything above 120 but lower than 130 is also considered acceptable. So a lot of the parameters they are raising. D is stable, exactly. D is stable. I still need to check in. They're still diabetic at the end of the day, but that's probably my last resort patient that I would see at the end of my day. Okay. Question number 6, which instruction should a nurse give to a client with diabetes mellitus when teaching about sick day rules? A, don't take your insulin or oral antibiotic agent if you don't eat. B, it's okay for your blood glucose to go above 300 while you're sick. C, test your blood glucose more often. D, follow your regular meal plan even if you are nauseous.
D.
So let's see. I see C, 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 C's. A
I
lot
would
of
say
C's.
D.
D, let's talk about it. The answer is C. Okay. Remember, check your glucose more often. Sometimes you may need your insulin adjusted, sometimes it is just fine. And you follow your regular insulin scheduled dosages. If you are concerned, you check your glucose, you call your physician, and they will be the one to alter your dosages. As the nurse, checking the chat, a lot of C's. As the nurse, let me go back. A is not appropriate. That is not my call to make. That is beyond my scope of practice. Okay. B is not correct. Going over 300 is never acceptable. Your glucose should not go that high, even if you're sick. Okay. And if anything, when you're
Oh,
sick, if you're not eating, your glucose will drop.
sorry.
Okay.
I thought it was med plan. Sorry. It's meal plan.
That's why I probably figured. That's why I said, let me go back. So regular meal plan, even if you're nauseous, no, we want you to
No, I thought it was med.
listen.
Sorry.
We want you to eat, but not if you're nauseous and vomiting because you can aspirate. So, we don't want you to continue to eat. If you're nauseous, you can aspirate. Okay, so the correct answer is C. Again, check your glucose more often. Sometimes if you're able to eat a little bit, that might be enough to keep your glucose, at a stable level so you take your insulin. Unless you're just not eating at all, nausea, vomiting, you just go ahead and follow your regularly scheduled insulin orders. Call the doctor if you are concerned. They will be the one to adjust your insulin while you are not feeling well. Okay. Question number 7. A nurse is caring for a client with type 1 diabetes who is lightheaded, begins sweating profusely, and loses consciousness. Which action should the nurse take? A, raise the client's legs. B, give the client 240 milliliters of orange juice. C, administer 10 units of fast-acting insulin. D, administer an IV bolus of 50% dextrose. So this is a good one. Okay. Now, by this time, you are recognizing the signs of hypoglycemia because that's what the
Was that
question is
B?
testing.
Oh, is that
Okay.
type 1?
Say that again, Miss Juliet.
No, I'm looking at type 1
So they are
diabetes.
type 1. But again,
You could give B.
this is about being hypoglycemic. So type 1 and type 2s can become hypoglycemic. It's a mix between B's and D's. That's what I'm seeing in the
Yeah.
chat. So let's talk about it. I think some of
But
you got
wait, the
some.
patient lost conscience, right? So he's not awake, right?
It
Uh-huh.
loses conscious. Yes, so they
Yeah,
can't
if
drink
he
the
lost
orange juice.
conscience and
They
he's
won't be
not
able to drink
awake,
the
that
orange
mean
juice.
he won't be able to drink the
Drink
orange
orange
juice.
juice,
That's like
right?
aspiration type of thing. So we
Yeah.
have to give him something
So
injectable
C.
or IV.
C.
Wait, who is this? Wait a minute. Who is that? Who is in the chat? Who is that? Who is that? That just said that whole pretty. I heard Miss
Oh, it
Juliet in
was
there.
me. It's me,
Who
Grace.
is
I'm
me?
sorry.
What's your name? Who's your name? Who is me?
My name is Grace. I'm Nurse Grace. Nurse Grace.
Oh,
It's
I know
me.
that's right. Yes, that was a beautiful explanation. You are exactly on the money. And a lot of you missed that. Okay. The client was losing consciousness. Okay. Even if they came back, they are in and out. They are an aspiration risk. We do not give them anything by mouth. That would have been an answer if they was not losing consciousness, because you want to give them a simple carb, bring the glucose up. Okay, but by them being unconscious, they are an aspiration risk. They will need the 50% glucose. I'm sorry, the 50%, the 50% dextrose to bring them up. Okay, so the sugar, that was an excellent explanation. You hit it right on the head. Raising the legs do not do anything for the glucose levels. Okay, if anything, it just promotes blood return back to the heart. John D. Yes, again, that was the key. You guys got to remember, okay, when you're taking the NCLEX, you got to make sure you pay attention. Listen, a little bit of critical thinking goes a long way. Even though drinking orange juice is typically an answer, because you want a quick, simple carb snack, bring that glucose up quickly, but the client is losing consciousness. They are an aspiration risk. What is the next best thing? An IV sugar glucose solution. Okay. Question
Can you
number
go
8.
back? Can you go
Uh-huh.
back to the
The answers.
the answers? Yeah.
Okay, there you go. So again,
Oh,
A
can
was
you go back to the answers, please? I'm sorry, I didn't mean to say
the
it like that.
rationale, the
Yeah.
explanation.
No, here, right here. That's fine.
Oh. Here.
Yes.
Okay.
Okay. I just wanted to make sure I got that.
No problem. So A is incorrect. Again, raising the legs does not do anything for glucose. B
Thank you.
would have been a good answer if the client was not losing consciousness. C is the opposite of what we want to do, because it appears that they're hypoglycemic. Giving them insulin is just going to drop the glucose even further and make the hypoglycemia worse. So D is the answer. IV bolus, 50% dextrose. We want to get that insulin, we want to get that glucose up quickly. Okay. Question number 8. A client is diagnosed with type 2 diabetes. Which referrals should the nurse expect to be requested for this client? Select all that apply. So remember, it is a team effort when we are managing clients with diabetes. Who would I expect the client to be referred to? So think back to your complications, body systems that are affected, BCD.
Yep.
I see BCD. Anybody else?
BCD.
I said, there it is. I see ABCD, ABD.
Oh,
So, okay.
podiatry. Oh,
Caught that. I
yeah.
see ABCD, CDB.
ABCD.
Okay, seems like you guys are kind of sort of on the same page. Julius put all of the above, A, B, C, D, and E. So the correct answer is A, B, C, D. Now, here's the thing. E is not a horrible answer, which is a dermatologist, but it is not expected that all clients will have a skin issues that are diabetic. That could be something that happens, but I wouldn't expect that to be a referral, because again, that's not common when it comes to complications, skin related issues. But not saying to rule it out, it's just not considered typical. Now, the podiatrist, let me go back to the answers. The podiatrist for the foot, or the ophthalmologist for the eyes, neurology is, the
Diabetic.
diabetic neuropathy, and a cardiologist. A nephrologist would also been a good choice, because that's the kidney person. Okay, so A, B, C, D. Some clients may need E. So E is not a horrible answer, but again, it's not common to see skin related issues in diabetic clients. It just may happen for a particular set of patients or clients, but it's not something that we typically see. So that's why A, B, C, D, those are the normal, regular providers that would be included in care for a diabetic client. 9, a client with type 1 diabetes mellitus is conscious but confused, weak, diaphoretic, and having heart palpitations. What is the nurse's priority action? A, administer glucagon intramuscularly or subcutaneously. B, give intravenous bolus of dextrose 50%. C, provide 15 to 20 grams of a fast-acting oral carbohydrate. D,
D.
inject 10 units of fast-acting insulin subcutaneously.
C.
So let's see. A lot of C's. So y'all caught it this time.
Yeah.
Everybody. The correct answer is C. Yes, you caught it. So same thing as the last question. However, this client
It's conscious.
is conscious. That was the difference. This client is conscious, which means they should be awake, alert at least, to the point where as they should be able to eat orally or drink orally and not have a risk for aspiration. Now, if the conscious levels was in and out like the prior client, then of course we will not give them anything by mouth because they would be an aspiration risk. So C, because and it was important that they put that the client is conscious. Again, okay, this client is conscious. You can get them some peanut butter crackers, quick, something to quickly pull the glucose up. That's what we mean by fast acting simple carb snack.
If they're conscious, carbs them up.
Yes. If they weren't conscious, nothing by mouth.
Not
That is a nursing judgment call.
I have a
Okay.
question. I'm sorry.
Yes, don't be
So,
sorry.
when I was taking the practice question,
Okay.
I think they put on there give the patient something to eat, and then one of the other answer was give them orange juice. Can you kind of like elaborate between the? I thought it was kind of like the same thing. I don't know.
Okay. It's the same thing in terms of carbs to bring the glucose up, but the thing is
Uh-huh.
you want something quick acting. That's the
Oh, it
difference.
worked faster. Okay, so the
Yes.
orange juice worked faster.
Yes, it works
So,
faster.
so if there is any answer with carbs and orange juice, always pick the orange juice.
Now,
Kind
but
of.
make sure you read the question and they tell you the client state because
Yeah, yeah, yeah.
if the client is slightly because we tell clients carry a simple carb snack also. And that could be something like peanut butter crackers. The thing is, how hypoglycemic is the client? If you're just starting to feel weird, okay, and you might not have orange juice on you, you can have a simple carb snack, like I said, crackers with peanut butter. But in this case, the client appears to be, they're on a verge, they're almost there. So you want something quick acting, and the orange juice acts a little quicker. That's the only
Okay.
difference.
Thank
It's quick
you.
acting. You're welcome.
Okay.
And last question, number 10. Oh, this is a good one. Who remembers? A client diagnosed with diabetes received 8 units of U100 regular insulin at 7:30 a.m. The nurse should be most alert to signs of hypoglycemia at what time during the day. So this is talking about the acting of the regular insulin on the
with A.
body. So let's see what I got in the chat. Oh, oh, oh. Now what? Now, how did that happen? Listen, this computer is way too sensitive for my blood. The correct answer is A. I see some A.
Yes, A.
Just works faster. Juice, I meant yes. Yes, Catherine.
Yes,
Just works
A.
faster.
Mhm.
A, B's, A's, A. So the answer is A, you guys. Let's go back. Actually, let me get back into slideshow. So let's go back and look at the time frame. So you had A, 9:30 to 11:30 a.m., B, 11:30 to 1:30 p.m., C, 1:30 p.m. to 3:30 p.m., and then D, 3:30 p.m. to 5:30 p.m. So the answer is talking about onset of action and peak. Okay. When we talk about peaks, remember what we said. This is the highest amount of time that the
Yeah, 2 to
medication,
4 hours.
2 to 4 hours. Perfect. Perfect, perfect, perfect. Because it peaks in 2 to 4 hours. That means 2 to 4 hours after I've taken the medication. That is the time that it works the best. So if I took it at 7:30 a.m., 2 to 4 hours later will be between 9:30 a.m. and 11:30 a.m. Because again, when you talk about the peak, this is the time frame that is going to work the best. That is another way to look at it. It's working the best in the peak time or so define peak. No problem, Ann. So when we're talking about peak, you're saying the time frame that the insulin will stay in your blood at its highest form or its highest amount. So let's say in this question, the client took, I believe it was 8 units. So for the next, because the peak of time is 2 to 4 hours, that means from 7:30 a.m. for the next 2 to 4 hours, because it's a range, it is basically saying that this is the time frame that the medication, the insulin is going to work the best, because this is the time frame that the insulin will be the highest in my blood before my kidneys start metabolizing and breaking it down. So if it peaks between 2 to 4, you can safely say after 4 hours later, which would be 11:30, the insulin is going to start breaking down. It is not going to be as effective in keeping my glucose lowered. So when we say peak, again, you're just simply saying
Stabilized.
the time frame that it takes for the medication to work the best. That is before it starts being broken down. And that is 2 to 4 hours. Okay. You're welcome. Is it kindly possible to share the notes? I'm not really sure what that means, but I know the recording will be available under previous webinars. You will be able to see that. Okay, so that's what peak is. Now, if they're talking about duration or onset, those are all different things. Onset is how fast does it work? Okay, onset means I took it at this time, it should start working by this time.
Working.
That's not peak. Okay, onset is just how fast. Peak, how long does the medication stay in my blood before it starts getting broken down? So if you're saying, again, in this particular case, 2 to 4 hours, that means this medication will be working at its fullest for the next 2 to 4 hours, and then it will start being broken down and excreted.
Last day, just.
Okay,
Mm.
regardless how many units, yes. Regardless, it is still the same insulin type, regardless of how many units. The units just depends. Now, somebody, if I'm not mistaken, if I remember correctly, asked me about sliding scale insulin. So, sliding scale insulin is another type of way to control glucose. Okay. Sometimes doctors will give you a set number of units. Like in this question, 8 units was ordered. That's a set number. When you do a sliding scale, you give the client more power because the sliding scale insulin dosage is based on glucose levels. So, for example, the order may be if your glucose is between, and I'm just throwing a number, 120 to 130 after you eat, you take 5 units of insulin. If your glucose is between 130 to 140, you take 10 units. So the number can change how much insulin you give yourself based on your glucose. Sometimes if you eat a higher carb snack or a higher carb meal, your glucose is higher, so your insulin dose is higher. On the flip side, when you eat, your glucose levels might be high, but not that high, so you don't need as much insulin. So it totally depends on what your glucose is, and the doctor will give you an order to cover for that amount. Okay, and they may say if your glucose is over this amount, you need to give me a call because that's pretty high and I need to see you and see what's going on. So that's what a sliding scale is. Your insulin that you give yourself is based on the glucose when you check it. Okay. Any questions with diabetes?
Uh,
Any questions?
I have a
Yes.
question. So I had like on UWorld, I'm looking at it about insulin. So the question was the nurse is preparing to administer medications at 0800 to a client with type 1 diabetes mellitus. When you
Okay.
look at the laboratory results, which I did, it said insulin 75 units subcutaneously. You're supposed to give it twice, the NPH. Then the Lispro, it's 4 times daily. But
Okay.
I did not see the laboratory results, but it says the sodium was good, potassium was low at 3.0, and the glucose was 328 milligrams. So I put the answer as minister insulin Lispro per protocol and insulin because it was high, right?
So it's wrong.
You know, it says contact the healthcare provider. I'm still trying to figure out
So
why.
it sounds like it's because of the electrolytes. So before I get into that, you guys, if you check the chat, I posted a link for the webinar for you to leave your feedback. Please make sure you click on that link and provide your feedback. You know how I like to do it. I love criticism. If it's something you want to see more of, something you want to see less of, anything you want to add, please make sure. Okay, so for the recording, it will be made available. Previous recording, I'm not sure exactly what time to be uploaded, but it will be uploaded under previous webinar. So it sounds like, now normally I like to see the question so I can answer this, but from what I'm gathering, it appears that it is the potassium. When it
Right,
comes
the
to,
zero, the
yeah,
3.0.
it sounds like the reason why you would have to call a physician, the potassium level is
No.
yeah. So you sometimes that happens when you are taking insulin managing type 1 diabetes electrolyte imbalances. Okay, so with the electrolyte imbalances, that is something that would need to be managed, and you would call the physician for that reason. Like, what do I need to do? The potassium is this number. What should I do with that? So that's kind of sort of, it sounds like what the answer is directing you to do. You call the
Yeah,
physician first.
but okay, so if you give the insulin, it drops the potassium more?
So it will, so diabetes does affect insulin. It is, now keep in mind some of the things we look, wait, how do you give the sub-Q to overweight? Insulin, okay, I got you. Insulin could worsen potassium. It affects, it's not the diabetes, it is the insulin management. So the thing is, you have to think when you have low potassium, you at risk for, the main thing would be the cardiovascular, the abnormalities, and the heart rate. So the doctor may order something else in addition to the insulin. It's like, okay, let's get this client this, like maybe, add some potassium to the IV fluids or, something like that of that effect. And then it's like, okay, you can give the insulin. The insulin is going to lower the potassium and make it worse, and you're going to see the side effects of that. So it's
Yeah,
not,
it says to give a supplement of potassium with the insulin.
it's not saying that you're not going to give the insulin. You are going to give the insulin, but you also
Right.
have to take care of that potassium first while you are also taking care of the glucose. So the thing is, it's not, see, with those types of questions, you have to consider, what do I need to manage first? So again, it's not saying that you would not take care of the insulin. They obviously need insulin. Their glucose is in the 300. That is high. The thing is, you just have to take care of the potassium because the insulin is going to make that worse. Then you can move forward with giving the client the insulin. So yeah, that's why I'm thinking they would add, what, maybe some IV fluids with potassium in it, something like that. It said a supplement, but something with adding potassium, and then the insulin would follow.
So how does insulin affect the potassium? I thought
It
it only,
excretes it. No. So remember, you can lose potassium.
oh, with
Um,
insulin?
You can. It help it secretes it. It lowers it a little lower. Sometimes we may have to give a potassium supplement. Now, if the levels aren't that bad, we would just tell the client to increase potassium in the diet. The green leafy vegetables and all that good stuff there. You're already supposed to be eating healthy anyway. So that kind of just, the pathophysiology is a little more complicated, but insulin does help to excrete more potassium. That's like the quick way to put it. It helps with secretion. So part of insulin management would be monitoring electrolytes for that reason. And if you do have a client that's hypokalemic, you would expect some type of order to increase potassium, whether it's via a supplement into the IV fluids or any other way that we could administer potassium to the client. Because we do not want this client to start having cardiac abnormalities in terms of heart rate. That's the last thing we want to happen. Please, can
Oh,
I
okay.
take one question answer to a person? Oh, that's a great question. So, how do we give insulin? So, now remember, sub-Q simply means below the surface of the skin. Now, if the abdomen is, severely overweight, that's not the only place you can give insulin. Okay. One of the things we teach clients when it comes to insulin administration, the sites, you have the abdomen. The abdomen is where it's best absorbed, but you can give it in the deltoids, you can give it the anterior thigh. For some people, it might hurt a little more in those areas. For what I've been told, for a lot of clients, they don't barely feel anything when they go to the abdomen. But you would teach them other sites that is just as good for observing as the abdomen, because they're going to have to change sites anyway. You're supposed to rotate within a week. So you move to a different area. You know, we teach clients you don't give insulin in the same spot. You can stay in that same area, but just move to another spot. And then every 7 days, rotate to a brand new spot and again start moving around. So if that is your situation, you have a client that has a little, extremely overweight, your best bet, you need to either find another location to give, or they may do something implantable. There is an implantable device option. Now, they may qualify for that. With the implantable device, it will read your glucose automatically and inject insulin into the bloodstream on its own, just based on what it picks up. Okay? Can we say type 1 is the characteristics of hypo? No, you can have both. With type 1 and type 2, you can have both hypo and hyperglycemia as the same. There's really not a difference in hypo and hyperglycemia. Both of them is about glucose management. One is
One
just
is
managed with
dependent, and
yeah,
one
one
is
is just managed
lifestyle
with
management.
insulin. Yeah, one is just managed with insulin. The other one is managed through oral glycemic agents and diet and exercise. But both you can see hypo and hyperglycemic in both. So it's not like one or the other you're more likely to see it. No, you can see it in both. Anyone else? Good questions. Anyone else?
But type 1, no insulin, and type 2, insulin resistant, right?
Yes, type 1, you have something is wrong with the pancreas, is damaged, the isolate cells, something, and it's not producing insulin at all. That's why you're insulin dependent. Type 2s, you're producing insulin, just the body is not utilizing it. So for whatever reason, your body is insulin resistant. Usually that's why I said we start with the weight loss, because for some people they just lose weight and then the body starts utilizing insulin. So yeah, it's just insulin resistant, but the insulin is there.
Okay, thank you.
You're
But when I'm have a patient with ketoacidosis,
okay.
but everything go down except for potassium, right?
With type 2, with type 2, the potassium might not be affected at all. Unless,
Okay.
remember, very few type 2 diabetics do need insulin. But for most clients, if they have a core morbid condition, remember what I said, sometimes with diabetes, some people they take they take more medication because they have a different condition also there, like hypertension. Worst case scenario, your kidneys aren't functioning appropriately, you have hypertension, you start experiencing fluid buildup, and what if you have to take a diuretic such as Lasix? Now for type 2 diabetic, now you still have the risk of hypokalemia, because now you're taking a diuretic, more likely is Lasix. And we know Lasix gets rid of sodium and potassium. So now you have a risk for hypokalemia for a totally different reason. But typically with insulin usage, you do see the issues with the potassium levels with insulin dependent. You don't typically see potassium issues with the type 2 diabetics unless they have to take insulin or they have a coexisting condition causing fluid backup. They will need to take a diuretic such as Lasix that will get rid of potassium that manner.
Oh, thank you so much.
You are so welcome. You're welcome. You guys are so welcome. You're welcome. Is there a discount if I purchase? For Miss Ann, I would send a ticket to support because I do not know the answer. I don't want to give you anything wrong info, but you can make sure that you can type and ask support. You guys make sure, I'm gonna post the link again. Make sure you click on that link and leave your feedback regarding tonight's webinar. Okay.
Thanks, girl.
You're welcome. You're welcome.
I learned so much since I started watching all these webinars
Angle. I'm
because
sorry. I think I misunderstood that. I'm sorry. Give me a second. You go, so you pinch. Okay. So you pinch the skin and you go in at a 90-degree angle. Yes. Yes, 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 yes. I think I misunderstood what you meant. When you say an angle, you mean how do you go into the skin with the needle? You pinch and then you go in at a 90-degree angle. Yes, that is how you do
Guys,
sub-Q.
I'm sorry, not to cut you off, Professor.
Yeah.
Make sure you go and look up that picture of what a 90-degree angle looks like.
Oh, no problem, Miss Grace, no problem. So your cheat sheet, I think that's what Miss Grace is referring to, the cheat sheet, how to do a sub-Q injection.
Oh, and
Okay.
I heard that for obesity, you're supposed to do a 90-degree angle.
That's what they're asking.
Right.
Yes, that's what was, yeah,
That's
for
what
sure.
they was asking if the client is obese. I think I misunderstood because I was typed, but yeah, that's how you would pinch. Yeah, but like Miss Grace said, the cheat sheet talks about how to do the sub-Q injections. Okay, you're welcome. You guys are so welcome. You're welcome. So if there's no more questions, I'll be back Sunday.
As I was saying, Professor,
Oh,
the whole I just started watching the lecture because when I was on the trial, I wasn't really watching. And then after I by the program, I started watching the lecture, and I was like at a borderline. And then I moved from a borderline to a high and just continue watching lecture. Now all the 85 questions in the cat that I'm doing is very high. So I'm really happy for that.
it's working for you. Okay, you a testimony. Listen, you got to leave a review. That's what the people need to know because people want to know, does it work? It works. Listen, the resources are great. I say it all the time. Naxlex has really great resources, you guys. Like from the practice questions to the cheat sheets, the video recordings, the webinars. Good night, you guys. The webinars, everything is there to help you. And remember, it appeals to different learners because I told you guys. Oh, you're welcome.
Thank you so much. Good night.
Nice.
You're welcome. You're welcome. Like I tell everybody, you have different types of learners. Some people are audio, some people are visual, some people like to read. And that's one thing about Naxlex resources. It appeals to all types of learning types. Um, the cheat sheet. So for my understanding, when you guys go through those practice questions, I know the cheat sheets are there. If Miss Grace can clarify, is there another way to get to the cheat sheets besides the
Yes.
practice questions?
Yes, like after you answer the question, they give you the rationals. If you click down the heading of what they're asking about in that particular questions, if you click on it, say like for myasthenia gravis or hyperglycemia, whatever it is that they're asking in that question, you click on it and it tells you everything about it.
So that's
Yeah,
the only way that
just
that's
right
the only
under
way.
it. Yep.
Yeah.
Okay, so when you answer the questions, when you answer your questions and you submit, once you scroll down, because that's how I see them. So I was making sure there
Yes.
was no other way. So yeah,
Yes.
when you answer the question and you scroll down, you might see a little animation, like a little picture there, but you scroll beyond that, you'll see like a link with, the name of whatever that question was focused on.
Right.
So
And you
you'll
click on
see
that
that.
and it brings up the cheat sheet. And they're
Yes.
very short too. They just go like short. You don't have to read too much. It just tell you exactly what that is. Yeah.
Yes, Doris. Yes. That is how you would get to the yes. You are correct. Meaning, yes, ma'am. That's how you have to do that.
Professor,
Yes.
I'm new here and I just got the 30 days plan because I've been looking for a good plan to use. And I think yesterday I asked the question and somebody said Naxlex is good. So I tried. So I bought the plan yesterday and I must say I really like it. Like the level because I actually got like one before. I didn't really like it. It messed me up. I was getting more confused. I think the level was very high. But I
Okay.
must say this one I really like the explanation and I'm getting better, gradually.
And honestly, that's the goal. Um, a lot of students, we tell you, the resources are there for a reason. And like Juliet said, if you utilize them and you answer the questions, you read the rationales. I always tell students, read rationales. Even if you get the question correct, read the rationales because it explains to you why the answer is what it is. Because you could see that question again written in a totally different form or asking something else. Regardless of how the question looks, the rationales are the rationales. They don't change for what's right and what's wrong. So not only are you getting questions to practice and other resources to help you study, you're getting rationales. And that is how you prepare for the NCLEX. You answer questions, you get comfortable answering questions, and then you read the rationales to understand. So moving forward, if you see that question again or something similar to it, I remember I read this rationales, your chances of answering that question is improved or increases.
Yeah, that's so true. And the takeaway is pretty good too. They have like a takeaway at the bottom of it that is like so cool. Like
It,
so
it kind of
cool.
summarizes.
Yes.
Sometimes you have to summarize and kind of put
Mm-hmm.
stuff, compartmentalize or create like a little acronym to help you remember because this is a lot of
Yes.
stuff. There's a lot that you guys
Yes.
got to recall for the NCLEX. So sometimes you just know the key, the takeaway points. That's like the most important
Yes.
stuff you
Yes.
remember
The
is
takeaway.
XYZ.
Oh, okay.
Yes, the
Yeah.
takeaway is just
Okay.
the takeaway is a bomb, trust me. Because sometimes like even when they do some of the other like another set, some of those takeaways help you in that other set. Because like when I see I'm like at a very high, my mouth is like open so wide. I'm like, what? Oh my God. And I didn't have to look up anything. I was just like going, oh my God. I was so
And the thing
excited.
is, that's what you want. Remember, the way you study for the NCLEX, and I tell all the students because they ask me a lot, how do I study? What do I do? There's no right answer for that because there's no blueprint. I tell the students when you sit down to take the NCLEX is adaptive, meaning based on how you answer the question, the next question is based off of that. So if you answer a question correctly, the next question is supposed to be a harder question. If you answer a question incorrectly, the next question is an easier question. And it honestly does not matter where the question
Really?
comes from. You're not going to know if it's going to be maternity, peds, med surg, mental health. You're not going to know that. You just know the client categories. So you honestly
Oh,
just have to be comfortable with answering questions. That's it. And with
mm,
the categories and the RATs that Naxlex has, you have the ability to practice answering questions to get comfortable because that's
Yeah.
what you have to be comfortable with questions.
Yeah,
mm,
that's true.
okay.
Because
But
the case studies was a huge problem for me, Professor. Like when I say I couldn't understand it at all, no matter how much I tried. And since now it's like I can see the first part, like the scenario and comes in and stuff, and right away I can say, oh, this is what this is. And then by the time going through it, it is exactly what I said it is because I'm starting to understand it. And this comes all through the
Application.
content. The content that I'm learning, it comes through that right now.
And so what you're describing is Maslow. So one of the things that we use when we talk about prioritization, we use Maslow hierarchy of needs. We use Bloom's taxonomy. Um, Sometimes when it comes to answering questions, you start with the very basic, like for example, it's Maslow's the very basic, and then you get into the higher levels. You can't do one before you do the other. So Bloom's
Right.
taxonomy, Maslow's, those are examples of levels that you move up as you take care of something. Like for example, with Bloom's, it's easy to remember stuff, but I tell students all the time, you're not going to pass NCLEX if you simply try to memorize. There's a lot of application involved. And the more you get comfortable and the more you get, with the material, you learn how to apply. That's why the case studies are getting easier for you because you're not memorizing to answer. Now you're applying your critical thinking. And that's going to help you on the NCLEX because honestly, you're not going to know everything. Like if you go into the NCLEX thinking you know everything, you might, kind of set yourself up for failure. You have
Right.
to accept, I'm not going to know everything. And that's okay. Because when you take care of clients, you're not going to always know everything right away. So it's the same thing with the NCLEX, approaching the NCLEX. How do I improve my chances of getting a question correct versus I don't know what this is and I'm gonna just take a big guess. You have to learn how to apply. And the case studies, they can be a little difficult because they're rolling case studies because it's like everything depends on the last thing that you did. But once you practice them, you get comfortable because I believe you're going to get about 3 of those on the NCLEX minimum. So you definitely
Oh,
want to be comfortable. You definitely want to be comfortable with those. You get about 3 of them minimum. I had a student that got 6 of the unfolding case studies. So all you do is just
wow.
practice. That's the only thing that you can do. Just keep practicing, you guys, until you get comfortable. And you have the
Okay,
resources to do that.
Professor, do I have to finish all the cats and the
Do
rats
you
before
have to? Now, will it help you? Yes, you should finish them because when you finish them, you get a report.
Yeah, I know because the day of my end test is fast approaching, and I don't think I can finish all the rats. Right now, since yesterday that I bought it, I did up to 6 cats already.
Okay.
So I don't think I'll be able to finish the rats
Do
before
some readiness.
I take the.
Well, those are the readiness assessment tests. When you get your report, do what you can do. Listen, the more you practice questions, the more comfortable you'll get. So I would just say just do as much as you can do, and you always look at the report that is given to you because it explains to you, where you stand, where you are. Just keep every day. Just practice questions every day.
Okay, right.
That's all you do. Just keep practicing the resources with the questions.
Okay.
Okay.
Thank you very
You're
much.
so welcome. You're
Thank
welcome, Mai. I hope I
you.
said that correct if you're still here. Any other questions, you guys? Okay. So remember, I'll be back Sunday. I honestly can't off the top of my head know what I'm covering on Sunday. So usually when we schedule, we do put the topics so you can see. So Sundays is mental health. Okay, so you guys can come in there. I know last Sunday I covered autism, ADHD, dementia, and Alzheimer's. So that recording hopefully is for review. So hopefully I'll see you guys back Sunday. So every Sundays and every Wednesdays. Thank you, Miss Ann, because here in Miami, girl, it is late. Thank you. So if there's no other questions, I will see you guys hopefully on Sunday, or I will see you back next Wednesday.
Okay, good night, Professor. Have a
Good
great
Good
night.
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 You guys have a
Bye-bye.
great night and be safe.
Thank
You
you.
too.
Bye. See you Sunday. I know that's right. Bye, you
Bye.
guys.
Bye.
Good night.